well, good afternoon. For those that don't know me, my name's Mark Salter. I've sort of pulled this afternoon together this afternoon, and I'm a consultant in Hackney, and I've been there for far longer than I care to remember, but still enjoying every nanosecond, which is a good sign. So what I'd like to do, first of all, before I introduce the speakers, and we have three distinguished speakers here, and I think it's fair to say they represent about, sort of sensible opinion on this issue as I think you could possibly get from who's currently practicing in the UK today, from three different, very interesting angles. And I'll explain that when I very briefly introduce them. You'll hopefully have already read their full biogs on the intro, and perhaps the little note that I wrote as an introduction to this. I'm interested to know that the wording of that introduction was a letter in The Economist that I managed to get published in January. And I was struck when I published it by the number of people who commented from all over the world. I'm talking about Israel, I'm talking about India, I'm talking about Canada and France, or people who sent letters to me. And they say, we find the same thing, c'est la même chose partout. It's kind of pretty weird. So, whatever we're talking about, or whatever pulse we have put our fingers on here, it is clearly more than just a London stroke UK phenomenon. Interesting thought. I want to frame the talks this afternoon, three talks, in the framework of a questions. And I'm going to put these questions to you and show you some evidence of why I think this conversation must be had on a far wider scale for reasons that I won't bore you with now. They will unfold naturally. The first question is this. Where are we? Is that on the screen there? Yes. Anyone here familiar with Goodhart's law, that great rule from economics, that when a measure becomes a target, it ceases to be an effective measure. Think about waiting times inside casualty or outside of casualty or waiting lists and things or anything you like, but that was an economist writing. But the minute you look at something and focus on it, the way you attend to it changes the way you see the thing you're attending to. Let's think about clinical attention. Are we seeing a patient with a life-threatening illness, or are we seeing a person with schizophrenia? The very language there changes the way in which we may or may not attend to this subject. And going back to good old Schopenhauer, an often overlooked philosopher, he makes this very interesting observation. Concepts will always remain universal, and so do not reach down to the particular. Yet it is precisely the particular that has to be dealt with, brackets, by psychiatrists, close brackets. Are we dealing with the particular, or are we dealing with the general? Let's just show what happens when we go from general to particular, okay? You tell me if you've seen one of these. A triage outcome letter from an assessment because it's too complicated for IAPT, so it came to our service. They decided they needed in-house low-intensity CBT. I deleted the name, but you'll be pleased to know there's no other identifying details in this at all. And they've been given a course of CBT with a waiting list of about 4 months. And their PHQ and their 17s are there to tell us how they feel about their fear and their depression. And that's it. Oh, yes, and at the end, PHQ, 0 out of 3, question 9. In other words, he's not going to kill himself. No current thoughts of suicide, deliberate self-harm reported. No risk from others reported. Should say no risk to the trust's legal department. But it does. Why doesn't it? That's the bloody truth. That's why it's there. Risk. Let's move on. Global Disease Burden Study 2019, paid for by Bill and Melinda. And this is in the WHO publication in the Lancet from 2020, just before COVID. So we can't use that as the excuse that we used, like the governments use COVID as an excuse for austerity. And instead, what we have here is, look at this, the young people of this age. Look at the global disease burdens. This isn't the rocketing rate of suicide amongst young girls. That's another fact I won't bother to bore you with. It's a fact. But look at this. Back in the olden days of 1990, 29 years ago, depressive disorders, low back pain and so on were down there. But look at those verticals from anxiety disorder, number 12, blue line, number 4. Look at depression, shooting up, depressive. Look at the top group of those people on the left-hand side of 2019 for young people. Road injuries, well, that's common. There are a lot of cars around. Headache, self-harm, depression, interpersonal violence, anxiety, and low back pain. 2 of those can refer to muscle spasm, which is a common feature of tension. I would argue that if you use a different diagnostic labeling system, a different way of looking at and understanding those poor, unfortunate young people, that's one syndrome. It's fucked up young person living in a crazy world who's anxious, tired, with back pain and headache, who's not getting on very well and maybe drinking too much syndrome. That's probably just as realistic as anything in DSM. But we don't do that by divvying it out. We make it look like it's the top 5 and they're all different somehow, aren't they? Is that soothing us from the fact that there is something seriously catastrophic happening to young people? Because that's the evidence. Remember, this is a global study. This is India, China, South Korea, as well as, you know, the comfortable West. So what is going on there? It's an interesting question. And the third piece of evidence, my lad, is this. BMJ careers, helpfully culled off of the BMJ website by my colleague, with I'm lucky enough to share a next door neighbour in office, Jonathan Pym, who's in the audience here somewhere. Nice way of coming in. And he culled this all together for me. Thank you, John. And he culled this together. This is the situations vacant posts for consultant specialist posts in this country. Acute internal medicine 29, cardiology 22. I know your eyes have already gone to psychiatry. Psychiatry is telling you there is an order of magnitude of greater job vacancies. WTF? Question mark. Why is that? So, young people getting really sick by the bucket load, psychiatrists seemingly getting replaced by locums by the bucket load, and a society that has a difficulty separating from the specific from the general, the natural, the human, the embodied, the lived, from the sterile labeled. Where are we going wrong? Well, maybe we can answer these questions, and I'm going to invite my 3 speakers today who have all considered this issue in their own private way in the year, most of their careers, to see if we can frame this as a question. I've deliberately arranged that there will be the best part of 3/4 of an hour, maybe half an hour, depending on how we roll, for a discussion afterwards, because most importantly, I want to hear from you, especially the younger people who are in at the beginning of their careers, because, you know, I'm coming to the end of mine. I've retired and returned already. But I would like to actually ask, you know, the younger people in this group to ask the questions that, you know, maybe the elders in this room might or might not be able to answer. And if not, why not? So that brings me to our first speaker straight away. Russell Razak is, I should add that actually all 3 of these people have inspired me in different ways. And the reasons I've asked them to speak is because of that. And Russell occupies a very special part in my life, literally, because he taught me to meditate many years ago with some of the workshops and the retreats that he did. And he was at that time working as a PQ consultant. And you know, he's committed to a Buddhist philosophy in the way he lives his life, and I try to. But the important thing is that Russell has devoted his work in many, many ways to some of the ideas that we're looking at here. You'll recall that he ran as a runner-up in the presidential election this year for last year, but that was won by Lady Smith for the Royal College presidency. And Russell ran on a single line. Let's put relationships between clinicians, he was careful not to say psychiatry, between the clinician and the patient back in the heart of practice. It's so simple, it's a no-brainer to me, and he didn't get it. I don't know about you, but I think that's a mess. But, you know, it just reflects more of the same of the things we're seeing here with all our little diagnoses and things. So that's what I think is really, really profound. And Russell is going to come and talk a little bit about those themes. And I will leave you no more than to allow Russell to take the stage. Thank you.
Thank you, Mark. It's good to be here. And back in, so I went to medical school here.
That's the screen's appearing in front of you.
Okay, well, thanks. So I went to medical school here, very long ago, actually, about 30 years ago. So it's good to be back in the Beerstead Theatre, where I started in 89 in my medical career. So I'm going to talk about compassionate and relational care. What does that mean? Referring a little bit to what Mark was saying before, in terms of, you know, the way we often do our business when we categorize things and we try to understand things in certain ways. What makes the most difference to the patient? What can we do to make the most difference to them? And how can we orientate the way we work that improves their outcomes? So, and just also to introduce myself, I have a couple of roles now. Obviously, I didn't win the Royal College presidency, but I'm presidential lead for compassionate and relational care and clinical and strategic director for the National Collaborating Centre for Mental Health. So that's on top of my clinical day job, which is a sort of research department in the college that is jointly in the college and UCL, and we do a lot of work for NHSC and other policy implementation bodies around the world. Now, what do we mean when we talk about compassionate care? Well, fundamentally, as Mark was saying, my slogan has always been about putting relationships back into the heart of care. And why should we do that? Why is the relationships we have important? Well, there's actually a really strong evidence base that shows the importance of the relational dimension of our care. What I have been saying for years now is that in psychiatry is always rested on two pillars. One of them is the relational pillar, and the other is the technical pillar. The technical pillar in the last half century has been mainly focused on pharmacology. There are other things too. But the relational pillar has historically been just as important, how we relate to our patients. Unfortunately, in the last half century or so, certainly the last couple of decades, that has withered, almost to a point of disappearing, where we've just become technocrats. So we look after patients a little bit like people look after a Formula One car in a pit stop. Loads of people crowd around it, and everyone does their little bit, but no one has a holistic view of the vehicle itself. Everybody's just got a little slice to do. So we tweak the dose, and the OT looks at their living circumstance, and different people, psychologists might listen about trauma, but there's nobody who actually has a holistic connection with the patient. And not only have we done that to ourselves in our profession, the system has also done that to us, creating a functional model where we don't really connect longitudinally with our patients and get to know them anymore. So putting the relationship back into the heart of care is quite a revolutionary idea, given how our system is organized at the moment. And the evidence base is what I'll start with, which is very strong. So about 30 years ago, Arlene and Gunderson did a study. They showed that the therapeutic relationship between the clinician and patient has a big impact on long-term outcomes. Even the relationship that exists in the first 6 months of treatment affects long-term outcomes. There was another study a few years later with Kroplik et al., and what they found is that regardless of the treatment people get, whether that's pharmacotherapy or psychotherapy, the relationship that exists, the words that you use with each other, the bond that you develop, that seems to have a big impact on long-term outcomes. Now, of course, from here, Rosemary McCabe and Stefan Prieb from, I don't know if Stefan's here today, probably did the best study on this in 2008, where they looked at psychiatric systems across Western Europe. So they looked at a whole range of settings, inpatient, outpatient, crisis teams, rehab teams, recovery teams, just across the board. And what they found consistently was that the therapeutic relationship is so important that it can actually predict outcomes. So the better the therapeutic relationship that exists between patient and clinician, the better the outcomes are in the long term. And that kicked off a whole flurry of studies. And in 2018, a literature review showed that there's now a really solid body of evidence to show that the therapeutic relationship has a massive impact on outcomes. Now, unfortunately, it isn't the way our system is orientated. The relationship seems to be a bit of an afterthought. System is organized quite differently. So, for example, continuity of care is not really the priority in the way our services are organized. Yeah, in some places, I guess it is more than others, but in general, the way our system is organized, and the people who designed that, so say a lot of the academics who I work with now who designed the functional model, do say themselves that we got this wrong, actually. We kind of invented conveyor belts that people seem to go between teams. When you get into crisis, you go into a whole new team, a crisis team. And then when you see the home treatment team, you see a new person every day who may never have met you. And you're at your maximum point of crisis. And some stranger will turn up at your door on Tuesday, and then another one on Wednesday, another one on Thursday. So how are we organizing ourselves relationally when we're doing that? So now we did, when I was in the general adult faculty exec, we did a survey of psychiatrists across the country, and a couple of hundred people responded. And then we did a Delphi survey. So we asked them some key questions like, what is the model of care where you work? And what are the pros and cons? What are the big things that you're happy about? What are the big things that you're unhappy about? And the biggest consensus was that there's one thing that a large number of people are unhappy about, plurality of respondents are unhappy about, and that was the lack of continuity of care. The fact that they don't maintain their relationships longitudinally with their patients, which incidentally is exactly the same finding on service user surveys. It shows the same exact thing. And when we went back to people and we said, how can we remedy this without abolishing the whole system? And there were some very smart, creative ideas, like the borders between teams being more porous, so people can continue to see patients between teams. like organizing hubs across teams so that actually the service follows the patient rather than the patient following the service. We need patient-centered services rather than service-centered patients, is what one person said. In other words, we don't have to create a system that patients have to navigate themselves around. We navigate ourselves around in order to be alongside them longitudinally. So there are ways of doing this, and there are models of care like Open Dialogue, for example, and other models that have done that and have trialed that and showed that it makes a massive difference in patient experience. Now, as well as improving continuity, there's some other key things that would make a massive difference in our ability to improve the relational aspect of our care. Gwen Adchett puts it very well. Many of you will have heard of her. She's quite a best-selling psychiatrist now in her books. Gave the Wreath lecture, I think, at the BBC last month. And the way she puts it is, words are our surgical tools. And this is very true. The words we use can make a massive difference to the patients that we have. It's not just about extracting information from them, but it's about how can we actually develop a relationship with them and how can we use our words to maximum effect. Thinking a lot about that is what therapeutic relationships are all about. And that means making sure that the patient feels heard every time we see them. Now, that isn't how we're always taught. We're often taught to conduct our assessment or our interview with the objective of extracting information, okay, or imparting information to them at the end, but not to make sure that they walk out of that thinking, oh, that I was really heard. That person really heard me. But the evidence shows that that is the single factor that makes the biggest difference in people's long-term outcomes. So the actual business of assessment is itself able to produce an outcome just by the way we talk, just by the way we make sure that they come out of it feeling heard. And that's not an easy thing to do. It's about creating a safe space. It's about making sure all the different voices are heard, especially if we're inviting other people in, which we also should do. It's about making sure that person has a sense of agency. And it's about making sure that they get that sense at the end of it, that they were able to say the things that were most important to them. Now, research shows that the ability of clinicians to do this is actually very variable. So some people do it very well, and lots of people don't. But there's a lot we can do to improve that, to shift the needle on that. So some of my early research was very much about this. What can we do for clinicians to help them improve relational skills? Now, a study I did about 12 years ago now, we looked at 76 clinicians, a whole range of people, psychiatrists, nurses, social workers, OTs, psychologists. And we did two sets of examinations. One is we looked at the Working Alliance inventory. So well, the first thing we measured their mindfulness, the Freiburg mindfulness scale. Now, the Freiburg mindfulness scale doesn't really measure if you meditate or not, or if you've even heard of mindfulness. It's nothing to do with that. It's just about how much sort of mindfulness you have as a trait. How mindful are you? How able are you to be present? And you're able to measure that in a well-validated scale. And then you compare that to the therapeutic relationships they have with their patients. And we found a very strong correlation. The more mindful clinicians were, the better their therapeutic relationships were with their patients. And I guess that's not surprising, because when you look at definitions of therapeutic relationships, it tends to be about how the focus really is on following the patient's utterance from one moment to the next, and not having a map in your head about, okay, you told me that, now let me ask you about this bit, which I have to fill in the Rio when I finish. It's more about actually being led by them. And obviously, if you're more mindful, if you're more able to be present, then you can do that better. And there's even good brain scans that show you the difference between this. So if we look at ScanB, these are clinicians when they're listening to people. If we look at ScanB, that's what parts of your brain you're using when you're purely just listening and present. And if you look at D, that's what happens when you're listening, and also thinking about what to say next. So as we can see, there are very different parts of our brains that we're activating when we're thinking about what we should be saying and doing next, compared to when we're just there with them, just listening in the moment. So they're two very different exercises we're engaged in. We tend to be taught to do D rather than B. We tend to be taught to think about what we should be entering in our notes and what we should be thinking next. So training around that is essential in terms of how we can help people to shift. And my more recent research is about what training works. And there is a lot of training that really does work, that helps people move across into getting better at just being listeners. It seems like an obvious thing, listening, we all do it, but not really. There's a difference between hearing and listening. We can all hear words, but can you really listen so the other person actually feels heard? Now, one of the factors that enables us to listen is the extent to which we can listen to ourselves. So Mark was talking about mindfulness retreats that I've been running for some years now, stopped after the pandemic and restarting now. But that's because practice of mindfulness or things like that, there are many things like that, enable you to get better at listening to your own emotions. And if we're better at listening to ourselves and everything that's going on for us, we might be better at listening to other people too. So if you think about it, a psychotherapist has their own regular therapy, on a regular basis, and they see a fraction of the human distress that we see in frontline psychiatric services, right? So what happens to all our distress? What happens to all that stuff that's going on inside us? Does that not bounce back onto the patient? Of course it was, because we don't have anywhere to put it. Supervision for us and for nurses tends to be about what targets did you follow, what bits of your job did you do, not about where are you emotionally, what's happening with all this stuff that's come onto you in the last few weeks. We don't really get that routinely. So I have a phrase that I've been trying to bandy around the college: no professional development without personal development. Personal development has to be essential to our own well-being and to the way we work. And this kind of well-being stuff that we have, it shouldn't be just what you get in a crisis. It should be what we're doing all the time. So good relational teams should be about actually making sure that the team has some regular personal development practice as well. But we can do things on an individual level. We can develop our own mindfulness practice. We can go on retreats. We can have coaching. We can have therapy, all sorts of things. These should be essential requirements for psychiatrists, as they should be for all mental health practitioners. And patients will know the difference if we do or if we don't. On top of that, at a team level, we can also do the same thing. Again, in some of the research I've done, things like open dialogue and other models of care, regular team self-work sessions is a routine part of the way the team works. Once a month, the team gets together, they sit down in pairs and they do things like genogram exercises, looking at their own families and backgrounds, what pushes my buttons, what causes stress in my life, what soothes me, what nourishes me, talking about that with each other. Tree of life exercises, memento. There's a whole range of exercises that teams can do together and pair up, maybe once a month for a couple of hours, just looking at themselves and understanding each other, connecting to each other. So at team level, that makes a huge difference. And the other key part also is reflective practice. Now, often multidisciplinary team meetings end up just sharing facts. So this is what happened with so-and-so, this is what's going on, these are the symptoms, and what should we do? All right. And there was a really good editorial in the BMJ by a GP actually some years ago, which was quite damning actually about the way mental health services conduct multidisciplinary team meetings. It talked about how you have a group of people, you have one or two people who've seen the patient, who meet with a whole group of people who've never seen the patient, and they all have a discussion together about what's going on, and they make a decision for the patient without them, and most of them have never ever met them, and then they dispatch the clinicians back to enact those decisions. All right. Now that's the opposite of a reflective team meeting. In a reflective team meeting, clinicians will talk about their subjective experiences. How does it feel to be in this position? What's going on? What might I be doing wrong? What might I be doing right? And being prepared to be vulnerable and just reflective about your own experience with your colleague. And then the rest of the team can reflect on your reflection. So you get some validation from the rest of the team about where you are and how it feels. And that emotional processing is what the team meeting is really for. And then you can fortify yourself to go back and share some of what you discussed with the patient and with their family. So a reflective practice culture is a very different one. Now, I've been working in teams that have a reflective practice routine for some years, and regularly what I hear from clinicians is that I don't know how I would do my job if I didn't have this space. It's essential to the way I work. And we build it in as an integral part of the team meetings so that it continues that way. What we have found now, we've done I mentioned open dialogue a couple of times. We have a very large trial. It's the largest model of mental health trial in the world at the moment, EDESI, looking at 5 pilot teams, open dialogue pilot teams across the country, in 5 NHS trusts. One of the key parts of what we did in open dialogue is reflective practice in every team meeting consistently. And I'm afraid I don't have results for you because they will be out in approximately a month from now. So, I'll have some data for you then. But one of the things we're announcing already is that it actually, we now already know that it improved the retention rate in a massive way. So in my service, for example, in Havering, so further out East London, we had in the control group, the treatment as usual group, we've had 100% turnover of staff since 2017. So all the staff in the team now were not in the team in 2017. They all left and one by one were replaced. And now it's a completely new team. In the open dialogue team, we have a 20% turnover. So 80% are still there from 2017. So that's a 100% turnover versus 20% turnover. And only those people who left, the 20% who left, only left because it's a small team. So if they had to go up to band 7, they had to leave and go to another team, often, usually with great regret. And we have a 20% versus 100% turnover. In other words, a 5 times higher retention rate in the open dialogue team. And we saw that in every single one of the pilot teams, massively improved retention in every single team. Why? Because they're getting to connect to their colleagues. They're getting to work on themselves. They're getting to share about how they feel. This job is an emotional job, but we don't spend very much time talking about our emotions. And it doesn't really work very. I remember a friend of mine who worked in palliative care. She said, if you want to go one place to avoid talking about death, you go to palliative care. We avoid it like the plague. It's not really a good way for us to run our business. I said, well, if you want to go to one place to avoid talking about emotions, come to a mental health team. No one talks about that. Right? And so we're going about this the wrong way. But when you do that, when you open the gates to that, when people can start sharing how they feel, and then creating a space for their patients to talk about how they feel, rather than just what symptoms they have, you find things start to really change. People want to stick in the team, and that alone improves continuity of care, because people aren't leaving the team, and you're not getting lots of agency staff all the time. You get the same people, maintain that relationship with the same patients. And what we also found is we did things like, we called it open door discharge. So when somebody's discharged, we tell them, you know what, come back to us whenever you want. You don't have to go through the GP, you don't have to go through service ABC, your access team. You come straight back and you'll see the same clinicians who form what we call network meetings. They form a network together, anybody who's important to the patient, all their friends, relatives, anyone else, we forward the care around a network meeting. And we can reconvene a network meeting anytime you want. And we encourage you to come back. The dog died, kids have left home, something happened. Don't wait till you relapse or become unwell. Just wait till things are difficult and we can start seeing you. Now, it might sound like, oh, how can you have the capacity to do that? Thing is, when we started to do that, we think, well, we're going to measure this. Well, you'll get the data in a month. That relapse rates start to reduce because they actually have that connection, that ongoing connection. So they know even after they're discharged, they've got that safety net. And it makes a big difference just to their sense of comfort after that, So these are the things that can make a massive difference. Now, as well as reflective practice, we also need to measure the right things, okay? Our system does not measure the right things. And even now, as NHS England, as the Department of Health are talking about putting a bit of extra money into here and there, they still focus on waiting times, okay? But what about the quality of care? What about the experience that people have of care? Are we measuring whether or not clinicians are empathic towards their patients? There's really validated ways to do this. So Strathclyde University set up a scale, a clinician empathy scale, clinical and relational empathy scale, the care scale. It's a fantastic scale. Now, I'm in my role in the NCCMH. We've been commissioned by NHS England in the new Culture of Care programme, which is delivering changes to the culture within inpatient wards. We're working with all 53 trusts across the country, and we're working with 3 wards in every trust. And there's a few things we're looking to do in each of those wards. And one of the things we're looking to do is to give out these questionnaires. We're putting QR codes along the corridors in wards, so patients can scan these QR codes, and then these questions will come up for them. And they can scan that QR code and answer these questions any time of the day, 3 or 4 times a day, after every interaction they've had, whether it's a ward round, a one-to-one session with a nurse, or just a chat in the corridor. Did this person really let me tell my story? Were they really listening to me? Were they interested in me as a whole person? They help me take control? Were they able to plan an action together with them? So things like this should be what we're routinely asking people. We're now talking to the CQC about incorporating this into, so Lard and I were sort of lobbying the CQC lead in mental health to try and start thinking about incorporating this into inspections in future. So if this is the kind of thing that trusts are going to be judged on in the future, then the culture will change. At the moment, they're not judged on anything like this. But we should be measuring the right things. At the moment, we measure what's measurable most, like what forms did you fill in? And that, doesn't really make the best difference. Right now, we tend to value bureaucracy over other things in the way that our trusts are incentivized and in the way that our inspections and regulators organize things. Well, we need to be putting the relational above the bureaucratic, so the humanity above the bureaucracy. So this is one way in which we might do that. So in summary, really, I'll wrap up and then I think we'll have a few minutes for questions. But in summary, really, these are the key things that I think we need to improve the culture and the relational dimension in the way we deliver our care, to make sure that those 2 pillars that we used to have, the technical and the relational, we'll always have the technical, we'll always be using pharmacology and other new technologies that are coming about in order to help our patients, but we need to rebuild the relational. And the way we can do that is by improving continuity of care. And we don't need to abolish the whole system we work in. We just need to make adaptations to it so that we follow the patient rather than them having to navigate themselves around us. We need to train in relational skills. Now, I've been teaching people in relational skills for over a decade now, but I also have to update my training all the time because we're learning new things about what makes a difference. And culture is changing all the time, so we have to change the way we talk along with it as well. So training staff in relational skills is key, making sure that personal development is integrated into all of our jobs and all of our trainings. Bringing reflective practice into all our teams so that we can share the subjective and our emotional experience and that not becoming an alien thing, the way our teams work. And measuring patient experience so that, you know, whether or not they're being heard is fundamental to the way this works. Now, as I say, the current incentive structure doesn't work. We're doing things now with the CQC, and hopefully that will filter down to commissioners and also with NHSC as well. Let's say the new culture of care program is particularly important and promising in that respect. We need to also research needs to be prioritized in things like this, in relational aspects of care, and we need to highlight where these things are happening as well. And there's collaboration going between myself and the other presidential leads at the Royal College. They're all leading on different areas, but this sort of runs as a theme all the way through it. And we also need to be creating alliance of professional bodies ourselves. It's no good just psychiatrists, you know, improving the relational dimension. Nurses have to do it. They have a lot more contact with patients than we do. This needs to be about nursing education just as much as it is for education for psychiatry. Similarly with psychologists, with social workers, and with all other professional bodies. And the ministerial rapid review that preceded the Lampard inquiry, one of their findings, I gave them evidence, and one of the recommendations was to have a alliance of relational and compassionate care amongst different professional bodies. So we're now waiting to construct that. So overall, if we do put relationships back into the heart of care, then we know from the evidence that it improves outcomes. It improves staff satisfaction by a huge amount. It improves patient satisfaction, and it also improves staff retention. And some of our research shows that that's potentially up to 500%. So all in all, it's probably a good thing to do. Thank you.
First of all, thank you for that. I know you've got to go now, haven't you?
I've got about
you've got about
10
10 minutes.
Yeah,
Okay.
yeah.
In which case, I'm going to ask people to throw questions at you for the next 10 minutes or so. I want to start out with one particular question that picks up on the practical spirit of your talk. That's simply this. Imagine that somewhere in here, this audience is a person who's been a consultant for just about a year. And they want to go away and they actually want to start a reflective practice group or some sort of session that will exactly implement some of the things you've talked about.
Yeah.
What advice would you give to that young man or woman going out there to do that?
Yeah.
And what pitfalls would you advise them to steer clear of, because you know they're likely to encounter?
Yeah.
Could you answer that? Is that a daft question, or does that
No,
make sense?
I think the first thing to do is you can't do anything in an isolated way, so you have to do it with a team.
Yeah.
So when we train teams, we tend to train teams, and there are trainings out there for teams. So at the Royal College, at NCCMH, we're delivering trainings now to teams, which are 3-day trainings, and it helps people develop, reflective practice in their team, as well as learn some skills around relational care. So I would tap actually us and NCCMH to try and get a couple of days of training into your team. You need some intro training so people can understand what it involves. And once you get that kind of intro training, then the team can start to work on actually changing their culture. How do we start amending the way we do our team meetings? Because what you do is use the existing spaces. None of this should involve creating an extra meeting or doing extra work, but it's changing the way that your team currently works. So a lot of teams do zoning, for example, and things like this. How do we change the structure of that meeting? So putting some thought into that, getting some outside support and training to how you can do that, and then change the existing meetings to become more reflective and give spaces for this kind of thing.
Okay, that makes sense. Thank you. I'll give other people a few questions first of all. Ian, please.
Yeah.
Can I just say one thing? This applies to everybody. That there's no microphone, I'm afraid, to go around, and this is being broadcast to another sort of 30 or 40 people. So if you could really from the diaphragm, Ian, that goes to all of you.
So yeah, thanks very much. It was talk very interesting. I suppose my reflection on it is: have you ever looked at community learning disability teams? Because I would say we do a lot of this in terms of like contributed care, open door, reflective practice, all that. And I agree, it's really successful. It's a really successful model, and really work on the relations with patients and carers as well.
Yeah. So it is true. Different specialities are at different levels with this. So yes, in learning disabilities, I've always found that clinicians there are already working in a lot of these ways. They can identify with it a lot more quickly. There's still we've had a couple of community learning disability teams who came on the open dialogue training, really benefited a lot from it to help to enhance some of that and learn some of the latest techniques around how you can really ensure the other person feels heard, ensure the family can work together, using systemic skills to work with the family. Because before the open dialogue training, the only systemic training you could do was like to train as a systemic practitioner, which was quite a lot. So this is a shorter way to develop some systemic skills that enables you to work with a network a bit better. So there are things that can be done, but yeah, you know, in CAMS, in learning disabilities, in certain specialities, this is a lot more natural and happening to some degree. Unfortunately, in general adult services, that's happening less than anywhere else. You know, so yeah, different specialities have different ways, but there's still new things that we can always learn.
Great, thank you.
Madam.
Thank you for the talk. It's really interesting. I was just thinking about how your thoughts on how we would balance continuity of care with the professional and educational needs of trainees who need exposure to different for psychiatry because they find this often usually us when I didn't see you again.
Yeah.
And
Yeah.
offered answers now.
Yeah, sure. So continuity will always be harder for trainees. But if we have teams that follow, so even in the course of 6 months, you know, you'll often see people who become really unwell and then they have to disappear and you don't see them. So if the teams worked with better continuity, then the trainees will have that too. So, you know, in some of our open dialogue teams, we had trainees who did their CT training while the open dialogue trial was running, and they developed continuity, really good relationships with those patients, which they would never have otherwise had because they could keep seeing them when they're in crisis, when they're in hospital, and then back out again. So you can still improve continuity, but yeah, of course, you'll have to keep moving every 6 months. But, you know, you can improve continuity within that time that you're there. And ultimately, most of your career will be as a consultant. You know, it might not feel like it when you're a trainee. I remember when I was a trainee, it was some distant dream. But once most of your professional life will be as a consultant. And that's when you have the opportunity to have real continuity. But in the training years, there'll be less, but we can still do a lot better. And we can still enhance that with so for example, you've got special interest days, ST trainees, and enabling continuity through that as well. And I've had trainees who've done, you know, sat in relational care teams who've managed to maintain those relationships by doing that as well. So there are ways we can improve that too.
Okay, before we ask the next person to speak, with Ms. Green jumper up there, I don't. Could you just people want to find themselves a seat, or others squeeze up, please? There's a lot of space further down, and
right in the middle there.
but please, no loitering at the back. Yeah, no drug dealing or anything like that. Please, just come on down, and there's plenty of spaces, or maybe some people who've got a bit of space could nudge up endwards. Thank you. There's shed loads of space here. You can even squeeze in past Professor Jeremy Coyd. But first of all, Miss Greenjumper, your question. Sorry, I don't know your name.
Hi,
From the diaphragm, please. I can just about hear you. That's great.
Yeah.
Hi, I'm Divya. I'm actually a new F1 staff thing, and I think Ian is my supervisor. I thank you so much, first of all, for the talk. It's so like affirming to hear us think about this quite critically in this space, given how it feels to like start working in the NHS and think, what on earth are we doing? I've just been working on orthopedics, where the relational care is like a million years different from psychiatry. And I was just wondering, how do you think we can, I think that the questionnaire that you put up for the QR code for patients, centering around like their experiences and how they feel about our care is so important. I'm wondering, how do you think we can like expedite that to other specialties where the focus has never traditionally been on the patient's experience and it's been incredibly paternalistic? Yeah,
so good question, but believe it or not, the question I showed you has been used everywhere else except mental health. Yeah, it's actually validated in oncology, in surgery, in gynecology, in dermatology, everywhere, but there aren't studies in mental health. It just shows you where the academic priorities lie. So it is used, it was actually developed for primary care, and then they used it in secondary care, and it has been used across every secondary care specialty except mental health. So it is used in other places, and it does apply equally, you know, because actually the patient having a sense of being in control, of being really heard, that is key and crucial. So, you know, there's actually a whole plethora of studies. So if you just look at Strathclyde University care survey, you'll find if you put it in Google Scholar, you'll find loads and loads of papers about all this stuff. But yeah, it is essential. And the great thing is actually that I found that these days, folks like yourself, people who've graduated recently from medical school, have a lot more sensibility around these issues because the training has already adapted to that. The selection process into medical schools is very different from when it was purely academic in our day. It's a lot more about emotional intelligence these days in terms of recruiting medical students. And so therefore, you're getting folks coming out of there looking for this, hungry for this, realizing that this is a fundamental part of the care we deliver. And so things are going to change in terms of the culture in which medicine is delivered. And research like this one around surveys like this will make all the difference. So it is, it is something that is moving across all the specialties now.
Okay. Right, so you're the flickering edge of my visual field. You're
Can you hear me?
Yeah.
John
please.
Lowe from Northwest London. Fantastic. I just love this. This is really, I would say it's timely, but it's really overdue, I think, this correction. But I want to say a couple of things. First of all, I think it's going to, unfortunately, I think it's going to be very hard because it's not happening. It's happened. And I want to give you a little anecdote to support that. But I also have a suggestion, one suggestion about how we might do something about it. So the anecdote is I work as a crisis team, and a patient requested that I follow her, that I stalk her to her community team meeting with her community consultant. And I thought, well, that's a good idea. It's like CPA, isn't it? You wouldn't believe the fuss that occurred. So first of all, her consultant said no, and the clinical director said no. I said, what are you talking about? It's all supposed to be open dialogue, isn't it? And they said no. I said, well, okay, I can't force myself upon you. Eventually, the patient complained, and they said yes, you can come. You know, reluctantly they agreed. So anyway, I went along, and it was very interesting. The patient was asked the same question 3 times. You might guess what the question was. Are you suicidal? Eventually, the patient said, I've answered that 3 times. Stop asking this question. So all these things are going on. It is quite incredible. And I wonder if there is a document somewhere, isn't there, in the dusty annals of the Royal College called Good Psychiatric Practice. Could we put in there somewhere that a good psychiatrist should follow their patient?
Yeah. Yeah, absolutely. I mean, that is exactly it. Following the patient is what we should all be doing. And we've lost the art of that. And people recognize that it is essential. But you say the system, I mean, a home treatment team member of staff could be disciplined for still seeing somebody after the 3 weeks that they were on the home treatment team. And yet they've seen them at their most vulnerable, the highest crisis in their life. If they did a good job, they forged a relationship with them. It's not a given, but if they did, then that could be really meaningful to the patient. And just to say hi, a couple of months later, how you doing, you know, connecting with them could have made a huge amount of difference to the patient. But that is screened out of our understanding of care in the system. So changing that will require a lot of heavy lifting. It's very true. And we have to change the sort of incentive structures and the way that people see our care at the very top. NHS England actually gets this. When I talk to NHS England, they totally understand all of this, but they're completely at a loss about what to do about it. This is what I've noticed. There's an issue of capacity and competence. They just don't know what to. But then lower down, ICBs, trust execs, etc., management, team managers, you know, there's sort of a wasteland of understanding around this thing. So there's a lot that needs to change in order to bring this about. But there is an understanding that these massive changes are needed because patients are suffering because of it. Our outcomes are a lot poorer because we don't do this.
Russell, I know you get to go, but there's one last question. Is that
Yeah,
okay?
sure.
Yeah. Teddy.
Thank you for speaking to us. I'm just thinking, you are welcome to Tower Hamlets. We do continuing care model, and
Yeah.
we had to stop that in the crisis, in the COVID crisis, but we're trying to get back to it. It's really, really rewarding for, I think, for the patients, certainly for the clinicians.
Yes.
But I also think we have to remember that we have good relationships with your colleagues. I've lost it here for 17 years. And that's mainly because when you have DNA, you go and chat to your colleagues, do me, and we chat about also important things. But I think we need to think also about the balance in terms of not degrading our training or our questions, because often you by screening, you're often finding things that are critically important, and you might miss because there's a huge barrier to talk about that. Clearly, when you have a relationship, you might much better get there. But it's always sometimes about the balance of thinking that we do good things. Do you know what I mean?
Yeah. So when we teach about, say, in sort of learning to do so a dialogical session with a patient, yeah, we very much do talk about how you can keep all of the you know, all of the sort of specifics that you want to ask about in your back pocket, and wait till the last third of your session to bring that up, and just go with where they're taking you, and ask them, do things like ask them to say more. Can you tell me more about that? Or use silencers, or just repeat some of their words to them. So that way you get them to keep talking without you telling them what they should be talking about. And what you find is that, I mean, I've been doing this now for about 15 years. What you find is that 9 out of 10 times, everything you wanted to ask, they already told you. And in fact, they told you in a lot more depth and richness than you could ever have asked them about. And it takes a leap of faith to do it first time. So we've taught about 900 people in open dialogue so far across the country. And we find that the first week of training, people are going, can I really do this? I mean, I've got such a massive checklist. Can I really like abandon that and just talk to them about what they want to talk about? And, you know, when I started in Picky, it was during a World Cup, and most of our conversations were actually about the World Cup, because that's what they wanted to talk about. But I developed that relationship, which really helped later on. But when you do that, you find that actually 80% of the interview, you've got everything you wanted to do, because they're taking you to it. Now, if you don't, and at the end there are things that you needed to ask about, you know, what are those voices really saying? Are they really taking it, etc. That you can, you know. But like I say, most of the time, it never needs you to ask it. You find out, but it does require a leap of faith, because there's like a mutual process. We have been fed these templates and these protocols. We also adhere to them because it makes us feel a bit safe. But letting go of them takes a little bit of effort. But when you do, you find that actually the patient feels heard, and I learned more than I ever would have done. But it takes a little bit of practice. It takes about 3 or 4 goes at doing it before you get comfortable and realize stuff actually works.
My argument is about the balance during seeing this bloody checklist. Once you get something there that is important, not to
you will need to complete
what
it.
we've been doing.
Yeah, you'll still need to complete it afterwards. But what I'm saying is that the way you get the information is it can be different, in which it creates a space for them at the same time. It does create, you know, it does create a bit of tension before you start doing it. But when you give them that open space, you'll find everything you need to. So the checklist is relevant questions, and we can't overcome governance. We can't not fill up the things we need to, but we go about achieving it in a slightly different way. And it does require a little bit of training and practice to do these things. And when we start to do it with people, whenever people start to do it, then they realize actually it is possible to have a free-flowing conversation, find out a lot more than I would have done if I just went through the list myself. But it is a culture changer.
Thank you.
Yeah. Okay.
Thank you, Russell. You want to get going? haven't you?
Yeah.
Okay. Thanks ever so much.
All right.
That's very interesting. Thank you. Right. Well, I'd like to press on with our second speaker, and with whom you are no doubt familiar. I like to think of him as one of the psychiatry's national treasures, really, because of what he's done over the years. Professor Oyobodi doesn't really need much of an introduction, so I won't give him a full one, just a slightly embarrassing one, which is this. You may know, of course, he's published extensively. He's got known in his field of the social and social determinants of mental health all over the planet. But what I think is fascinating about Femi is the way that he pops up everywhere in all sorts of places. As a poet, of course, as a philosopher, and some of you, of course, will have heard his Psychiatry working series on BBC Radio 4, which I think is, when you think of the target audience of the British listening public, I think it's a masterpiece of getting things across in a very skillful way. But also he does it with psychiatrists. You may go back to the bulletin about 15 years ago, the Apothecaries. Remember that short paper you published? And Femi said, you realize that branches of the medical profession can die off with no one noticing. It's a very, very interesting thing to look at. Go back and look at Apothecaries Oyobodi in the bulletin from about 15 years ago. He's a staunch member of the philosophy section at the Royal College, another interesting thing. But it seems to me every time I'm listening to, that lovely masterclass you did on the role of the perception of time in mood disorders. Bergson's theories about time. It's very, very interesting stuff. So anyway, this is a man who truly is a polymath and a scholar, as well as a practicing psychiatrist and professor. So Femi, you're going to give us a talk. Well, I can't remember the title of your talk.
Thank you.
I'm sure we'll all remember it. Thank you.
Thank you very much, Mark. You're very kind, generous introduction. I hope you can hear me. I usually give that disclaimer at the beginning because I don't use any overheads or slides or anything like that. So you're not going to be able to take photos of a slide or anything like that. So you're just going to have to hope that you can follow what I'm saying and that I don't lose track of where I am. So I just thought I'm using the idea of a crisis to be the hook that I'm going to follow in this next 30 minutes or so. And using the word crisis because when the BBC asked that I be involved in the series, the Psychiatry Working, the whole idea was psychiatry was in crises, and we had a trial recording session which never made it to the actual program, where Robin Murray was very kind they wanted to check whether my voice was good enough for the BBC, and I was panicking whether my Nigerian accent was going to make me suitable or unsuitable for the BBC, and just to see whether I knew how to talk to people, to camera and to the microphone. And so the first question I asked Robin Murray was, Robin, do you think that psychiatry is in crisis or not? And he said, all my life, they've always said that psychiatry is in crisis. It's not in crisis, he said. So that was Robin. So I thought I'd use this idea of a crisis. And I thought that it's very difficult to follow Russell because he's proposing solutions. And whereas I'm really talking about problems, and I'm hoping that the problems will get us to talk about potential solutions. So I thought there are three aspects to this in my way of thinking. One is that there's a crisis which is to do with diagnosis. Secondly, that there's a crisis which is to do with systems of care. And thirdly, that the problem with the systems of care is because of problems to do with treatments, because you don't get discussions about systems of care in general medicine and surgery, because the treatments, they're not perfect, but the concentration is on treatment. So you don't argue forever about whether you need relationships or not, even though you do, but you don't spend a lot of energy doing that. So there are three interrelated kind of, in my view, crises that we need to approach. So if we come back to the diagnostic practice, so we inherited Kreplin's a kind of system, and that was invented in the sixth edition of his book, published in 1899. So it's about 125 years old. And I'm always disappointed to find that really able leading members of our profession want to argue that we don't need Kreplin anymore, that we're in the post-Kreplinian world, and which means that you've got really senior people, leading academics, who just talk about something called psychosis, which I think is a problem, because it means that you no longer have to think properly. You just no longer have to make any distinctions. And that can't be right, because it's just like saying, this guy's got a fever. you don't care whether it's due to malaria or whether it's due to, whether it's to do with a TB, pulmonary TB, or what, it just doesn't make sense to me. So I want to talk a little bit about the crisis and diagnosis. And I'm at risk of always blaming the Americans, because the Americans got us to move away from psychopathology to ticking little boxes. Therefore, that damaged the interest of the young psychiatrists in listening properly, because they're just looking for buzzwords and they just tick these boxes. And therefore, you end up with people not listening. So if I come back to diagnosis. So if you think of the idea of psychopathology, so you think of Jaspers. And when you think of Jaspers, one of the pillars of Jaspers is this business of what he calls empathic understanding. I mean, he talks, and to talk about empathic understanding, that Jaspers is making the distinction between explanation and understanding. And he's making that distinction because he's basing his whole system on Wilhelm Dilthey and Max Weber. So it is crucial in our profession to keep that distinction in mind. And Jaspers, of course, he wants to use the idea of empathic understanding for two purposes. One, he wants to say that things like anxiety and depression, you have a fellow feeling for them. So he wants to say there's, the German word Versailles, that these ideas that if you see a human being who's crying, and that human being tells you their mother's just died, you have empathic understanding. You understand why it is they're crying. And then he wants to say that there are some experiences which are understandable. So when he says they're ununderstandable, the whole purpose of saying something is ununderstandable in Jasper's terms is to say that it's a process, what they used to call process schizophrenia, and when he talks about process, he's saying it's something to do with your brain, so it's cerebral disorder, so it's not to do with human life. So he makes this distinction by explanation and understanding. An explanation in his terms is the natural sciences, is Newtonian physics. And in the English tradition, you would normally have said there are causes and reasons. That humans, when you say to somebody who is angry, why are you angry? They give a reason. And if you say, why is it that guy, when he bumped into you in your car had a dent in it? That's an explanation, it's natural sciences. So that's the distinction he's trying to make. So to come back to empathic understanding, which is lost because the kids just want to tick a box. And we spent a lot of time in the first session talking about essentially, we didn't use the word listening, but essentially it's listening. So attentive listening. And you do attentive listening because you want to understand the person. That's just, I'm sorry to have to repeat what those of us of my age, we just knew that was true. And that chap, his name escapes me, which is something to do with my age. Well, the chap in Manchester, who used to talk about the conversational style of interviews. And I say to my trainees, there's a difference between an interview and an interrogation. I mean, they're different things. And so a conversational style allows you to do what Russell was talking about, that the students, medical students sitting behind me, they thought that I was just going to have a chat with a patient over a coffee table. But of course, I knew exactly where I was in my schedule. So you let people talk to you, and you are talking to them, and the less you say, the better for the interaction, obviously. And I, when you get to my age, you start to use anecdotes. And Patrick Gale, the novelist, I interviewed Patrick Gale, one of the Birmingham literary festivals, probably about 7 or 8 years ago. And Patrick Gale said to me, he said in front of this audience, said, the whole purpose of my life is to write in such a way that the person who is reading doesn't know they're reading. It obviously is an ideal. It's not possible to read and not know you're reading. But what he meant was, he said for him, he has to write as if they're looking through a pane of glass so that the reading is effortless. Well, the same should be for psychiatrists. So I interviewed him, and before he knew it, he was telling me about his mother, telling me the poor relationship he had with his mother, and this, that, and the other. And at the end, he turned to me and said, I don't know how you got me to say all that. I said, I'm a psychiatrist. So that is the trick. The trick is to use as few words as possible to achieve the most possible. All right, so that's all I want to say, that there's something wrong at present with the fact that we've lost psychopathology, and that psychopathology had a purpose. And the purpose of psychopathology, Jasper's psychopathology I'm talking about, was to have empathic understanding. And you cannot have empathic understanding by ticking a box. So you have to listen. In order to listen, you have to know how to talk to people, which is where a conversational style comes in. So you're not interrogating the patients. And then, of course, we can have the solutions that Russell has been talking about. And then I want to move on to talk a little bit about the crisis in the kind of, the kind of care, the models of care. And to do that, I need to give you an anecdote. And it is true, an anecdote. And I know that there are lots of people who are wedded to this rubbish system that was introduced in the late 90s, round about when Tony Blair came to power, so in 1997 or thereabouts. Completely rubbish system. So to give you an example, I have a real patient of mine. I used to cover the university medical practice. He's got bipolar disorder. He turns up in casualty. He's tried to cut his penis off. So the surgeons have got him. They've some bits of it back again. He's seen by somebody who is supposed to be a liaison psychiatric nurse, who phones me up to say, he came in last night. The surgeons have done with him. I've seen him, and I think he can go home. And can you give him an appointment? And I said, when was the last time you saw somebody who tried to cut their penis off? So I've never seen one before. And you think he's only been in hospital for 24 hours, and you think he's well enough to go home. So I went to go and see this person, and obviously he's ill. I mean, you don't have to see him to know he's ill. you know. I mean, you could guess that, couldn't you? It's unbelievable that somebody thought that he was well enough. He'd only been 24 hours. So I said, he needs to be in. I'm a senior person. By that time, I've been a senior psychiatrist for 40 years. I had to get somebody who was a bed manager or something like that, who said, you can't admit him. You haven't got a right of admission. I said, thank you very much. What should I do? So you've got to talk to home treatment first. So I talked to home treatment, who said, yes, we'll go and see him. So the home treatment went to see him, and they said, oh, yes, we agree. He needs to be in hospital. So by this time, he's seen me, he's seen the liaison psychiatric nurse, he's seen home treatment, who said, yes, they finally agree with me, as if they could possibly not agree with me. I mean, just imagine that. And then they admitted him onto the bed, and then they discovered at the end of the week that because he was under the age of 25, he ought to be with early intervention. So he's seen me, he's seen liaison psychiatry, he's seen home treatment, he's been in a general adult psychiatric ward, and then they moved him from there to early intervention. So he saw 5 or 6 different people in the first week of the first episode in hospital. And that's true. I've not made it up. It's a real case of mine. That's disgraceful. And all the things we've discussed up till now won't solve that. Because if you're wedded to this funny idea that there's somebody called a hospital inpatient doctor and somebody called home, you are dealing, and then you want to say you want continuity. How do you get continuity of care in that arrangement? And you're just, so forgive me, I just don't think what I've just described can be solved by anything else but just recognizing that you can't have these teams. Don't work. And if you're wedded to them because you like working with early intervention, or you like working in assertive outreach, or that is just selfishness, because it means that you're not interested in the patient. So and there's a problem also with the language of care, the language of psychiatric care. And forgive me for being a little bit cynical, but who do you tell me? Have you found somebody who doesn't like community care? Community, wonderful, isn't it? I mean, I'd like to have community care because it's in community. Community is somehow naturally superior to the hospital care. Because it is nice, warm feeling. I'd love it too. But my next door neighbor had multiple myeloma, had to be treated with a steroid, and that's the first time he had a manic episode. He lives in Birmingham. The only bed in the whole country that was available to him was in Devon. In the whole of England was in Devon. It's real, I'm not making it up. So he had to be detained and sent to Devon. And his wife then had to go and rent a house or rent a flat or something in Devon in order to be able to visit him. Oh yes, wonderful community care. It is, isn't it? Very, very nice. So there's a problem with language, the language of mental health services, that relational, compassionate, they're very wonderful. I mean, I'd like them, but you get them. And calling them something which is nice doesn't give access to them. So you've always got to be very, very careful with the way in which words are used and what people are trying to do, because they're doing persuasive communication with no proper regard to actual services. So Darzi has done this wonderful report for the government. And Darzi, he says that the thing that's wrong with psychiatry is the same that's wrong with the whole of the health service. So we haven't spent enough money on actual fabric of the services. we don't have enough nurses, and this, that, and so he catalogs these problems. And then he says exactly the same stuff he talks, which always sound very, very nice. We spend too much money on hospitals, and we need to move all that money into the community. There are very, very few psychiatrists who are doing their jobs conscientiously who think we've got enough beds. It's not because, I had a debate in 1994 with Sashidaran, who some of you would have heard of, in public like this, there are hundreds of people sitting, and he went on and on about the fact that psychiatrists like beds and this, that, and the other, and that we don't need them. We don't need these beds. So I got up and I said to him in front of everybody to say, well, I don't get an orgasm just looking at a hospital bed. And he was very surprised that I said, I don't have a fetish over hospital beds. He took him a while to grasp the idea of what a fetish was. No, that's serious. So we don't have a fetish over beds, but we need them. That's true. We just need them. And needing them is not a bad thing. It's not because I'm a wicked psychiatrist that I think people need to be in hospital. It's just they need to be in hospital. You just have to accept that. Don't feel bad about the fact that you need to admit somebody. I mean, when the home treatment service was introduced, because it all came from Birmingham and I worked there, and this person obviously desperately needs to be in hospital. So I went to see the nursing team. I said, this person needs to be in hospital. She said, we failed. This nurse said to me, we failed. And I said, what do you mean you failed? Oh, because they have to go into hospital, we failed. I mean, it's a really strange idea that somebody who's desperately ill, I mean, would you say you failed when you got somebody who's had a stroke or somebody who had a burst aneurysm, that they need to be, oh, how terrible, we failed. What do you mean you failed? They just need to be there just so that we can look after them. And of course, we were trading on the kindness of their families. The last anecdote, and I'm Nigerian by birth. I went to medical school in Nigeria, and we used to get external examiners from Britain when I was a medical student. And this guy came from, I can't remember his name, came from Britain when I was in final year. And in those days, we used to do day surgery because we're a poor country for hernia repairs. You came in the morning, we did the hernia repair, and we discharged you home in the evening because we didn't have enough beds. We weren't proud of it. We did not write it up in the BMJ. No, we were not proud of it. We were terribly ashamed of it. And this guy said to us, can you imagine that you're doing that? And then I came to Britain, 1979. By 1982, there were papers in the BMJ saying how wonderful they were doing daycare for people with hernia repairs. And they were proud of it. They were writing stuff in papers. Just, what's wrong with you guys? And they wouldn't say to their patients or to the country that we're doing it because we didn't have enough money. Whereas we knew we were doing it because we didn't have enough money. Do you know what I mean? So I think you've got to be very careful about these things. You've got to think very, very carefully about them. So there is a problem with Darcy, because he has this idea that he wants to move money out of hospitals into the community. We need money in the community. We just don't want to move them out of hospitals. And finally, he has this idea that medicine would be so much better if there was preventive care. Now, we have no idea what to do to stop people getting schizophrenia or bipolar disorder. We're not about to spend all the money we should be using for people who really need care, who don't get enough care at present, move it out of the care that we're given, which is inadequate, and move that, to do preventive work. And if you agree with that, I think you ought to review it all over again, because I just don't think we know enough about what to do, and the care we give at present is under-resourced and it's not good enough, and our patients aren't receiving the best as possible. So we just have to be able to say, because preventive care is another of those things, preventive medicine, another of those things, which is very nice. So you've got to be cynical about the use of words, because who wouldn't want to prevent something? So you can't say in public that I just don't think prevention is the answer at present, because it sounds as if you're a wicked person who wants people to suffer first before they can. And finally, so I've already made the point that, that we are preoccupied with systems of care because the actual treatments aren't good enough. All right, because the discussion, I mean, how can we, at a meeting like this with psychiatrists in the room, how can we talk and talk and talk and we don't talk about treatments? I mean, we're doctors, for God's sake. So if you're a medical student and you come and listen to psychiatrists and you're thinking, they haven't even talked about treatments. They're just talking about home treatment. They're talking about assertive outreach. And you think, but what about the patient who is ill? So no discussion about what we need to do in order to get the person as well as possible. So again, to go back, so we know that these drugs that we use were introduced in 1952. And so they just, I was born in 1954, so they're just slightly older than I am, so 72 years or something like that. And we know that all of them, they're cousins. There's nothing particularly different about all the drugs that we use at present. So, we make claims about some side effects and this, that, and the other. But basically, we are stuck. We've been stuck since chlorpromazine and imipramine. So chlorpromazine, 1952, imipramine, 1957. We've been stuck since then. And so we definitely need to find a way to start to think slightly differently. I'm not here, as you know, I'm not here to be put, I don't have any shares in, companies who make ketamine or colleagues of ours have companies which are currently licensed to make psilocybin, so I don't have any shares in them, anything like that. And I don't particularly think particularly highly of these psychedelics, but we ought to be speaking with one voice at the idea that there's a paradigm shift which these new drugs give us a little bit of a window to start to grasp. So the paradigm shift is that with antidepressants, you would have been lucky if you were well after you've been on them for 6 weeks. And we've got a little bit of a hint that some of these agents can make you better in hours. And we've got to grab that. And I don't know how we do it in order to encourage people to do more research on them and to try to work out what exactly it is in these drugs that make that happen and so on. But we need to be finding our voice to say, we're not talking about psilocybin in particular, but we're saying the psilocybin and ketamine, they're giving us a hint that there's a way in which these absolutely nasty conditions can be altered in very, very short periods. And it may be that they need to have, intermittent dosing over time rather than be on the medicine forever. But there's a hint that these drugs are different. And then to keep in mind that these drugs give us an idea that brain-derived neurotropic factor is important. And we should all be speaking with one voice about what is it, how are we going to get either brain-derived neurotropic factor itself or some other substance which is much more directly gets it to be secreted in the brain to ensure that our patients feel better. And the final thing I want to say is we did the BBC program, and the second series, I always think of the name, very interesting, the controller of Radio 4, was insistent, I think of controller as somebody who controls in a kind of malevolent, way, I don't think of it as a kind of benevolent sort of person. I think, oh my God, is 1984, he's going to be controlling us and listening in and so on. But anyway, so he insisted that we've got to find a way to do something optimistic and hopeful, because the first series was full of what psychiatry wasn't good at. And I proposed that we look at mother and baby units. And some of you may have listened to the programs. And mother and baby units, they're extraordinary. They are, I don't think anyone's gone through them who complains that people who go through adult psychiatric wards. So mother and baby units, the focus is totally on the mother and the child, and everybody is working towards the same purpose, which is to ensure that we safeguard the bonding and the relationship between the mother and the child. Everybody's focus is there, and it's properly multidisciplinary. So you've got pediatric colleagues involved, you've got health visitors involved, you've got consultant psychiatrists involved. Okay, well, look, while you're doing that, I might as well introduce the third person. I made no shame of the fact that every single person I've asked to speak here has inspired me in some way, but the third speaker, I think, is a particularly important person because I actually worked with him as a consultant back in 1994 until he left in 2002, I think it was, Martin. Yeah. And Martin is an unusual person in many, many ways. And the ways that I'm allowed to talk about here are to do with the fact that, I'll put it another way, does anyone here know Don McCullum?
Yes.
Good. Some people do, some people don't. He's a war photographer. Well, you're about to hear from Psychiatry's answer to Don McCullum, really. And I think it's fair to say that he's worked in he's chipped away at many a coalface of human suffering. And perhaps the toughest place he's ever been to, in a different way from all the rest, was Hackney in 1994, which was a strange place. Some of you here will remember it. And Martin, along with me and a guy called Trevor Turner and a woman who has a ward named after called Ruth Seaford, all three of them in their ways were my mentors. And Ruth sadly is no longer with us. We did this. We divvied up, or we were responsible for, catchment area, Hackney, London Borough, 210,000 people. In 1994, it was way poorer than it was now. You would not walk down Richmond Road at 3 o'clock in the morning unless you were sensible, or that you were actually strapped and you had a lot of money in your pocket. But otherwise, you wouldn't do that. That was that kind of thing. And Martin, he did the Northeast, I did the whole of the Northwest, otherwise known as Stoke Newington. And we covered these quadrants, and this was our job. No senior registrar, unless you were lucky. And we ran, at that particular coalface, 4 GP liaison clinics, a community mental health team, newly opened, 1994, an adult general forensic outpatient clinic. Yes, Jeremy, we were doing the 37.1s in the community years before you even came to your beautiful Furo bunker. I was there. Like I told you at the Garrick. Oh, sorry, must mention the Garrick. Groucho. Sorry, Groucho. Please forgive me. I wanted it again. And So yeah, a CMHT, Adult Forensic Service. Oh, prison in reach, don't forget that. Yeah, and I've mentioned the Forensic Care Service. Yeah. Oh, sorry, the GP liaison, you name it, we did it all single-handedly. And, we had serious incident inquiries. One of them was on Panorama. That's another story. And it was remarkable, but that's nothing compared to what Martin's also done. Gulf War I, Gulf War II, Ebola epidemic, one-off. Gas attacks, tube disasters, crane crashes, that means King's Cross fire and the Paddington fire. Basically, Martin has got this amazing ability to be aware that ever shit is happening. And he's got this uncanny instinct for these things. And it's a result of that, and Gaza, and Kyrgyzstan, Sarajevo, the list goes on. But Martin has travelled and worked in many, many areas. And he's published 2 very interesting papers in the Yellow Journal, which are 25 years apart. The first was Psychiatry in No Man's Land, ? And the second paper, I think, Martin, was Psychiatry
No Man's Land after all these years.
in No Man's Land after all these years. And so it's Martin, I'd like us to welcome him to sit down in front of you, because he's going to give a talk which is roughly along the lines of,
I was going to say,
what's your title?
The same, but they'll all leave.
Okay, more of the same. Over to you, Martin. Thank you.
I have to thank Mark for inviting me in and letting this happen. And I'm going to sit down, partly, 1, because I'm old, 2, because I've got a pair of new shoes on and they're digging into my heel and my foot's bleeding. I'm in absolute agony, so I'm fine if I sit down. So I hope this is okay. I hope everyone can hear me. And I'd also like to just say thank you for coming, and thank you all those people listening or watching online, including, I know there are people in Australia, in California, in Northwest London, in Central London. I'm very grateful to you all. I'm flattered and humbled by this. I don't know how many of you have read the paper I wrote in the British Journal of Psychiatry earlier this year, but it's one of the first few things I've ever written, and I've written a fair few papers in my time where I've got sort of fan mail and hate mail, and mostly fan mail, I have to say. But it's quite astonishing. It touched a nerve with a lot of people, and it was basically just comparing and contrasting how things have changed. And I'm mindful that I don't want this to be a moan, and I want to offer a few practical solutions. And to preface what I say, I'll admit there are big positive things that have happened in the course of my career. And if I had to point to one thing that I think is more positive than anything else, I think it's the reduction in stigma around mental illness and the fact that we can talk about it more openly than we ever could. And Mark, I remember many years ago, ran an anti-stigma campaign for the college, which was successful in its way. And I'm sorry, please don't be angry with me for this, Mark, but I think what really made the difference was celebrities coming out and speaking out about their own mental health problems. But for sure, people are talking about it. People are more willing to be referred than they were, and that has to be a good thing. On the other hand, we now have a wave of diagnoses and conditions that services simply can't cope with. And I'm mindful of adult ADHD, for example. And one of my big fears at the moment is that with a finite budget, no matter how much that budget's going to be, with the ADHD burden, if that burden is put onto community mental health services, something is going to have to give. And it worries me that that's going to be the severe enduring mental illness and the people with schizophrenia and the people who really need us. So that's maybe a subject for another day. But I just want to draw that to your attention, because I think it's any solutions I suggest today or options for change. I'm trying to avoid anything that involves a lot of money, because it ain't going to be forthcoming. Yes, of course we need more beds. Yes, of course we need more staff. But I'm going to try and suggest ways that things might work better without just going with a begging bowl to the government. So that's by way of preface. Now, I totally agree with the first two speakers, and thinking back to Russell Razak's talk about therapeutic relationships. I've often told our trainees, and I'm not sure online if you have a camera can see this, but I've often told our trainees, whatever, our therapeutic toolbox is quite limited, and it hasn't changed, as Femi said, that much since 1958 and tricyclic antidepressants in 1952 and chlorpromazine. But I've always said, and I still say it today, unfortunately, that if the effect size, okay, of any treatment, whether it's psychological or psychopharmacological in psychiatry, is that big, and for those of you who haven't got a camera, I'd say 20% of the effect, the therapeutic relationship is that big. And no treatment, and I'm not just talking psychiatry now, I'm talking about the whole of medicine. No treatment is going to be fully effective, even if it's an antibiotic for a chest infection, unless that is set against the background of a good therapeutic relationship. Now, in my day, we didn't have communication skills training at medical school. We just sort of picked it up by sitting and watching what our consultants did. Nowadays, they do. And what they do is pretty good. I'm sure there are people who are far closer to it than I am, but they learn the basics. But what they don't learn is how nuanced it can be. And sometimes we still get it very wrong. And it's having a therapeutic, there is no one size fits all. And my worry about Russell's talk is that therapeutic relationships themselves will be operationalized and reduced to tick box forms. So empathy, tick, open questioning, tick, blah, blah, blah. And there is no one size fits all. And there's an example, I should say, the reason I'm putting these slides up are to keep me on track, because the two things I do badly, and I get worse as I get older in any presentation, is I get sidetracked. That's the first thing. And I tell too many anecdotes. But I will bore you with one or two, and forgive me. When I was a medical student, I worked on the professorial unit at Barts, and the beds were shared by two consultants. One was the professor of medicine, who was incredibly, he was a brilliant man, Mr. Essential Hypertension. He had a world academic reputation. And the other was a jobbing renal consultant. Great doctor, but no academic pretensions. And we'd go to both their ward rounds, and they'd share the beds on the ward. The professorial ward round would involve a gaggle of students around the great man in their white coats. And he would articulate his thought processes. So he'd stand by the bedside, look at, hear the information about the patient, hear the history and physical examination findings. And he'd say, well, on the one hand, it could be this. On the other hand, it could be that, or it could be something else, and he'd articulate his, and then when it came to treatment, it was exactly the same. On the one hand, we could do this, or we could do that. And I remember the patient one day tugging at my white coat and saying, here, does that geezer know what he's talking about? Okay, contrast that with the renal consultant who'd come to the foot of the bed. He'd look over his half-ring spectacles at the OBS chart, and he'd look at the patient and he'd say, point at the patient as well, you're going to die. And there'd be a sharp intake of breath, and he'd pause for dramatic effect and then say, but I'm going to save you. Now, which one do you think was the more popular? Not the professor of medicine. And that taught me, I learned more about communication skills from the consultants whose firms I was on as a student than ever I did in a lecture theatre in a classroom. And I do worry that a lot of the communication skills training is so stereotyped and so set in stone almost that it doesn't take account of those things. And in terms of the patients, we live in an age of consensual treatment where patients come for diagnosis with a wodge of internet self-diagnosis. And handling that is something I hope students are being taught today, because it's really difficult when they do come, sure of what they've got, knowing what treatment they want, and they just want you to sign the prescription. But there is no one prescription or one size fits all. And I think a lot of it has a generational effect to do with age. So as patients get older, they like you to be more directive and to explain to students and trainees, there are some patients who you really have to wag your finger at and say, do as I say. And then there are others where you have to accept and listen to their point of view. And judging that, that's part of the skills of being a good doctor. And you can't learn it in a classroom. And that's what we have to, if you're going to have a good therapeutic relationship, you have to judge that, the information that you give to the patient, how much you listen, how didactic you are, how dictatorial you are even, you can't do it on a tick box form. You just get it from experience. So I do worry that although, student communication skills training is good, and yes, I accept that we're accepting students who have greater emotional intelligence and not just on academics, but it's still pretty damn well academic, if you ask me. A very good friend of mine is an organisational psychologist who was hired by Edinburgh University to improve their student selection. And she resigned in disgust in the end after one selection round, because she said, quite rightly in my view, listen, when you interview these people, don't ask them science questions because they've already got their A-level predictions. They're going to be straight A students. Test them things about their emotional intelligence and how they relate to other people. And she said that they couldn't cope. The consultants on the selection panels couldn't resist asking them to tell them about, Newton's laws of physics or chemistry or whatever. And it was reverted, and no matter how hard she tried to drum into them, it always went back to the academics. So I think, there is a change in student selection, but I think that change should go a lot further. I think there's a problem once students get to medical school, and the reason I'm telling you this is because consistently throughout my professional lifetime, about 2% of graduating medical students have interest in mental health and psychiatry as a profession. And I think that shows there's something very wrong going on, that, why is that? And I think there's a lot of reasons, although I think stigma in society has reduced in our lifetime, stigma within the healthcare sector and medical education is as bad as ever. I well remember at Homerton Hospital years ago, walking past a bunch of students who just bumped into the then dean, who was a very progressive lady at the time. And I overheard her saying to them, oh, what specialty are you doing these days? And they said, oh, we're doing our psychiatry attachment. And she said, oh, don't worry, you'll be doing proper medicine again soon. And I thought, well, what hope is there for people like me when the dean of the medical school says something like that publicly to medical students? And of course, I hope, well, if you haven't experienced yourself, you'll know a friend who has, but within the healthcare sector, when we ourselves have mental health problems, our colleagues are incredibly unforgiving. And who, I think, was it Russell at the beginning, made the joke that, you know, if you want to talk about emotions and mental health, don't be a mental health professional, because we don't talk about it. But we're very unforgiving of our colleagues when things go wrong. And goodness knows we are in a high emotionally fraught, tense environment all the time. And, you know, we probably have more than our fair share, but people mask it, cover it, conceal it. And, you know, it's sad that we talk the talk, but we don't walk the walk when it comes to our own people. And that brings me to one of my underlying themes. There's going to be a lot of waffle and digression in this talk, but one of my underlying bullet points and things that I think we need to change, not just in psychiatry, especially in psychiatry, but in medicine as a whole. When I was a student, although I got shouted at a lot, although I was treated like a school child a lot, I felt cherished. Okay? We don't cherish our students anymore. We don't cherish our trainees, and we don't cherish our colleagues. And I think that is something that's been lost in medicine, and I think that needs to change. And the reason I say this, I'll just give you a couple of recent examples. I've just had a Brazilian exchange student who's just qualified in medicine, came to work with me in Londonderry, where I've been for most of the last year. And we had a session with patients, and I tried to engage her with the patients and got her involved. And she was so excited at the end of it. At the end of the day, I, you know, said, how was that for you? Was that all right? And she she burst into tears. And I thought, oh my goodness, what have I done wrong? And she said, I've been so used to standing in a corner and being ignored or feeling I'm in the way and not feeling I can ask anything. And this is the first time I felt engaged and part of a process, you know. And I thought, and I didn't make me feel good. It just made me think, what the hell is going on in medicine when that happens? And I see the medical students on the general wards. The last 3 months of my work in Ireland was in liaison psychiatry in a big general hospital. And you see the students sort of skulking, trying to not be in the way and avoid making a fuss. It's just so sad. And they're not, you know, and the trouble is, the junior doctors who, you know, in the old days, we used to have a firm and it was a family, and I've written about that, and I won't bore you in the detail now. You know what I'm talking about. But now the junior doctors themselves are all on shifts. So the patients never see the same person twice. The students hardly ever see the same person twice. And the consultants likewise come and go now. So you can be admitted to a general hospital with quite a simple, straightforward problem and see 5 or 6 different doctors. And then when you add on to that the nursing staff, and heaven forbid, many wards now rely on bank staff, and they're different every day and they chop and change all the time. And what hope is there for a decent therapeutic relationship or continuity of care? So I think the 2 things that need to change in medicine, apart from we need more beds, we need more money, of course we do, but assuming we're in a climate where that's not going to happen anytime soon, we need to cherish each other and our students and juniors particularly, and put ourselves in their shoes and imagine, you know, how we would feel if we were being treated in the way they are in similar circumstances. And secondly, echoing what Femi and Russell said earlier, the therapeutic relationship, which I think is so important. And actually, although Russell did, you know, he demonstrated in several papers showing that this was a good thing. If you actually look, there's a paucity of research on the subject, and most of it comes from dynamic psychiatry. But this isn't just, you know, from dynamic psychotherapy. This is, as I say, it's pertinent to the whole of medicine. And good consultants know how to do that and exploit it and milk it. The less good ones just stick to the figures and treat the patients, you know, the patient is reduced to being a case. Something I always taught patients years ago was never, 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 or taught students years ago and trainees, never, never, never to refer to a patient as a schizophrenic or an epileptic or a diabetic. They are a gentleman or woman of a certain age who has diabetes or an epilepsy-like illness or a schizophrenia-like illness. And that people would think that I was arguing, you know, angels on a pinhead and just being semantic. But it's so important, because in your mindset, if people start talking about the diabetic in bed 10 or the schizophrenic in bed 12, it reduces that patient to a case, and you stop thinking of them as a human being. And something that was said earlier that I totally endorse and want you to think about is this business of tick box questionnaires to assess our patients. And Mark at the beginning put those ghastly low level CBT letters up with the rating scale scores on. And that I think is an absolute travesty. And I tell you why. I think this is important. Moreover than any specialty in medicine, psychiatry is a messy, complicated business. Patients lead messy, complicated lives. They don't conform to what's in the textbook. They don't do as you tell them. They're often non-compliant. They can be, they can love you one minute and hate you the next. For all sorts of reasons, it's a messy specialty. And the trouble is that makes it very complicated to deal with. Now, I worry student education today and the education in doctors and other specialties actually militates against looking at complex pictures and reduces everything to tick box questionnaires. So those of you who've been on general wards recently, News 2 scores, looking at vital signs in a very systematic way. And you don't say to the patient anymore, how are you feeling this morning? You look at their News 2 score, and if the News 2 score, if the oxygen sats are okay, the pulse is in a certain range, the blood pressure is in a certain range, then they're okay. And bugger saying hello, good morning to the patient. They don't do it. Or a lot of them don't do it. The good ones do. And what I'd say is that our students are brought up in largely a general medical and surgical culture where they're exposed to three-dimensional, colourful lives that are reduced to one-dimensional tick box monochrome. And that's what they become accustomed to and used to. And so when they come to do their psychiatry rotation, or they come to work as a trainee in psychiatry in their FY jobs, they see these messy, complicated patients that don't really, the tick box forms don't do them justice at all and don't explain their, the richness and diversity of their lives. And I think they simply can't cope with it. I think they prefer to stick to the tick boxes these days. And one of the reasons is that we get so much information in medicine these days, so much data that comes all the time, and ever more lab tests, ever more physiological monitoring and so forth, that we get to a point where the complexity of what we're looking at becomes overwhelming. And as Mark has written, or is about to write, I hope, that what happens under those circumstances is the brain can only handle so much complexity, and we get to a point where we retreat from it. And one of the ways in which we retreat from it in medicine is by the tick box questionnaire approach. And whether it's a psychological rating scale, or whether it's the News 2 physiological monitoring for physically sick patients, and it's quite difficult. It's, we do live in a different culture, and although, my goodness, we have more than our fair share of tick boxes, it's still, we still deal with messy situations, with complex situations that simply don't occur in other specialties. And I think that puts people off because they're simply not geared up to it. They're not equipped to deal with it. So I think managing that complexity in medical school and actually inculcating in the students that that not to allow them to be reduced to these one-dimensional tick box assessments of patients. So I think if we go further in attracting medical students with greater emotional intelligence, and I should say I think there's a lot to be said for after the first year or two training, a preclinical training, or the first couple of years of training now in basic sciences and a bit of clinical. I think there's a lot of medical students who vote with their feet, and they either leave or they decide medicine's not for them, but some of them stick at it because their parents want them to, and they'll be cross and so forth. I think there needs to be some mutual, there should be a vehicle for transition to other degrees with honour, without it being appearing as failure. So one of my jobs is dealing with an organisation called Doctors in Distress, for example, who are people who've mostly fallen foul of the GMC and the Medical Council. I met a chap online. I spoke to him last week, and I mentor some of these people, but he was a graduate of a very distinguished university. Well, he wasn't a graduate because he was suspended on the day of his graduation. Okay, which is a bit mean. But anyway, both the GMC and the university authorities have got their teeth into him. And he hasn't committed murder. He hasn't done anything particularly heinous. He's made a silly mistake. And I was exploring, I said, look, realistically, you're gonna struggle to graduate. You're going to struggle to get the GMC to register you, and then you're going to struggle even more to get a job. Have you thought of anything else? And exploring that a bit. The options for graduates at the moment, medical graduates or people halfway through their course of going into other specialties like biomedical science or nursing even, is really, really limited. And I do think there should be more, opportunity for CrossFit or for moving sideways with honour. That's the point. People can move sideways, but they say, oh, you're a failed medical student. That's wrong, I think. When medical students graduate, at least we have FY jobs in mental health now, but please don't, treat them nicely and think of them as big students, because where I worked in my previous job, these FYs were put on call. They started their rotation on a Monday morning, and some of them were put on call by themselves on an acute ward on a Sunday night, which is just not a very good introduction. And thank God they all came through it okay. And there were, consultants on call were made themselves, they actually proactively phoned them to say, how are you doing? You all right? But, they need to be treated appropriate to their level of experience and expertise, and not just chucked in at the deep end as cannon fodder. And psychiatric trainees. When I was a trainee, I trained at the Maudsley Hospital in the days when they like you to do medical membership first and do not actually get the exam particularly, but just do 2 or 3 years of general medicine. And I must say, as I get older, the idea that people should have a little broader life experience, a little broader work experience, and mature a little bit more before they get thrown into mental health for the rest of their lives. I'm a bit of a believer in that. And I should say, thinking of the Maudsley and training, Femi mentioned at the beginning of his talk, Robin Murray, Professor Sir Robin Murray, who's a lovely man, and as I'm sure you all know, Mr. Schizophrenia, or Mr. Psychosis, as he might now be called. But he interviewed me for my place there. And why did I do psychiatry? Well, first of all, as a medical student, I had to do my attachment in Hackney Hospital, and I lived near the end of the runway at Heathrow Airport, and I had to go back on the tube and the train every day because my dad was disabled. And all the consultants in Hackney on the different firms were warned off about me by the medical school. They said, look, if Deal doesn't turn up on time, don't be hard on him because he's travelling a long way. It's taking him hours to get here. And if he's the last one there or he doesn't turn up, it's fine. I was quite the opposite. I was always the first one there and the enthusiastic one. And there was very charismatic teachers at the time. And one of them, Professor Trevor Silverstone, some of you will know in this audience, now dead, sadly, but used to let me sit in his office and read his books at lunchtime and actually made a fuss of me. And why did I go into psychiatry? Well, one, because charismatic teachers made a fuss of me, which they didn't in many other specialties. And also, two, I mentioned stigma as a positive that had come out of my professional lifetime as a positive in psychiatry. In my second year at university as an undergraduate, before I ever studied medicine, I studied biochemistry because I couldn't get into medical school when I was 18. So I went and did a biochemistry degree, but I thought if I hung around with the medical students enough, they might let me transfer, but they never did. But in the second year, I was sharing a room with a second year medical student who had a psychotic breakdown. I'd never seen mental illness before. He was in hospital, he was sectioned for 3 months. And in those days, if you went to Oxford or Cambridge, you didn't get the run through for 6 years. You had to apply for the clinical course again. Okay. And he applied and he was rejected by the Oxford Medical School. And then he applied to every other medical school in the country and was rejected. And they said to him, well, look, you've had this breakdown. Go away and prove yourself that you're stable for a year and come back and we'll give you a place. So he went to Sussex University and got the top degree master's degree in experimental psychology they'd ever given. Came back, applied again, was rejected. Applied to every medical school in the country, was rejected. And grudgingly, after his father threatened to sue the Oxford Clinical School, they gave him a place. Now that man, apart from being my best friend, now dead sadly, went on to be a hugely successful GP, a much loved, beloved GP. And I'm sure that experience of mental illness actually made him all the better for it. But what I saw at the time and what disgusted me at the time was the stigma that went on, because basically they just didn't want him to qualify because he was mad. He'd had that episode, even though he made a complete recovery. And at all sorts of levels. And I think sometimes we delude ourselves and assure patients that they're going to be treated fairly in the workplace, in whatever situation, and they're not. There's still, and I think what demonstrates that most is we ourselves, when we have problems, we don't actually go to our managers and say, you know, I'm really depressed and suicidal, or I'm drinking too much or whatever, we hide it and sweep it under the carpet. We might whisper it to a colleague that we trust, but we don't use the chain of command in the way, or occupational health, that we're supposed to. So that's another thing. Now, you know, training, I'm aware that the chief examiner of the college is in the room somewhere. Ian, are you there? Where are you hiding? Oh, he's gone. Has he gone? Oh, no, he's there. I've got to be careful what I say now. But I think there are big training issues as well. I think, you know, we learn a lot of science, but oops, hang on, how do I go back? Hang on. We learn a lot of science. Fiddle with that in a minute. But I think sometimes the actual training experience itself needs to be, at the moment you have the exam, which seems a bit divorced from clinical day-to-day practice. And you have trainees saying, oh, I have to go off and have my study leave time. And you say, well, don't you learn from the patients you're seeing? Oh, no, that's different. It's very separate. Whereas, you know, I'm not boasting, but when I did my membership, I was allowed the afternoon of the exam off to go and do the exam, and that was it. You didn't get any, you weren't expected to take leave. You were expected to learn on the job. And I just worry slightly that, was that me? Have I done that? I just worry that the exam has become a little bit detached from clinical reality and maybe needs a little bit of rebalancing. I'm trying to be as kind to you, Ian, as I.
No, he's taking it up for.
Yeah, no. Now, how do I go back with these slides? Go on, tell me how I do it.
One tool's for
Oh,
that's it. That's it.
yeah, okay. Okay, so, right. Assuming the trainees still want to do psychiatry when they actually have got their membership and done their specialist training, we have several issues. I've put here at the top locum la la land. I've been a locum for the last year. I've never thought of locuming before. And I'm used to working in an environment, i.e. here, where everyone is a trainer or a trainee. And one of the reasons I put as the third bullet there, what's the point of the MRC Psych? And I was mentioned briefly to our chief examiner at the tea break, is that I've come across trainees in this last year who have narrowly missed passing the membership by a point or two. They've narrowly missed it. They've done it again. They've narrowly missed it. They've got young families. They're at the age where they've got a couple of kids. And instead of persevering, they're offered a trust grade job, a consultant salary, given consultant responsibility, and with a vague promise that they'll go through the cask process. You know what I mean by that? Used to be Article 14, that they'll become consultants on the basis of experience one day in the distant future. Of course, hardly of them ever do that, because it's so damn difficult to get through the bureaucracy. But they don't know that at the time, a lot of them. But by the time they get there, they don't care anyway, because they're treated as a de facto consultant. The only thing is they're not paying the membership subscription every year because they don't have it. So that's my issue, again, with the membership, that there's a lot of people in very senior positions taking massive responsibility who don't have that exam. So it does beg the question, what's the point? Now, back to locums and my experience. The trouble is, as a locum, we heard how important it is being part of a team and reflective team learning and things like this. You're never really part of a team because you're on a 0 hours contract and you can be here today, gone tomorrow. And I used to think that the reason hospitals had such high rates of locum employment was because they couldn't keep full-time staff. And it's only dawned on me in recent months that's not actually strictly true. And it seems to me that in certain cases, hospital trusts actually want a significant cadre of locums because they don't like to see bullshit. Because the thing about a locum is that your opinion is neither sought nor requested, or or if you give your opinion, it's not welcome usually. And so they don't want a big army of bolshy consultants. They want an army of expendable consultants that they can get rid of at a moment's notice. And I discovered very recently that a lot of consultant locums are there because it suits management, frankly, including medical management, and a small cadre of regular substantive consultants who basically sort of run the show from their point of view. So I think locums are bad for patients because we come and go like ships in the night. We're bad for teams because we never feel part of a team. We never contribute to service development because our opinions aren't sought and unwelcome when we give them anyway. And of course, those of us or those people who do 0 hours contract are on, not ridiculous sums of money, but they're very well paid. And there's something iniquitous about being paid, 25, 30% more for doing the same job as a colleague in a substantive post, and who's getting less. And and in my, I think and locoming is good if you want to travel, if which is what that's why I've done it in the past. But I do think in an ideal world, for everyone's sake, for the service's sake, for the patient's sake especially, I think we should go back to aiming for everyone being a trainer or a trainee, and not one of these middle level grades. Staff they're all sorts of things: clinical fellow, staff psychiatrist, trust grade doctor. They have all sorts of names these days, but the basic thing is they haven't got the membership. And so I think we should aim that the membership is the sine qua non, is the gold standard, and that we expect them all to get that, and we expect a service manned by consultants and trainees and no one else. Burnout and moral injury is really difficult when you haven't got the tools to do the job and you've realised you're not doing a good job. And it was mentioned earlier about day case surgery, which was driven by financial reasons, but vaunted as a great step forward. And I think we need to be more honest than that, because that's a really important reason for losing personnel. And also, I'd add, the government wants us, as we get older, people like me, to return to work from retirement, which is fine. But I'd say, if I've been through the experience, once you lose your license to practice, or you're not up to date with your CPD and your appraisal, getting back on that ladder is not only incredibly bureaucratic, it's incredibly expensive as well, and it doesn't militate in favour of people coming back to work who've been in the service and have left because of retirement, or women who've had babies and families and then want to come back to it several years later. And there's not many return to work courses that they can do either to get back into the swing of things with developments. So burnout, moral injury, return to work from retirement, and then moving on. Right. The specialty itself has difficulty. I heard a wonderful presentation a couple of weeks ago from the American Psychiatric Association in New York, showcasing some of the new electrical developments in electrical treatment that are around these days. We know about ECT, obviously, and transcranial magnetic stimulation, but there's now all sorts of variations on that theme, which I'd never heard of. And of course, deep brain stimulation and ultrasonic ECT, which I'd never come across. And there's a list of things which are undergoing evaluation, and some of them showing great promise. Now, the trouble is, if these are accepted treatments and taken on as conventional treatments, they're going to be done by neurologists and neurosurgeons, not by psychiatrists. So I mentioned at the first the big squeeze. So we're squeezed on the one side by if more physical treatments are adopted in treatment of mainstream mental health, that we just have to refer to neurology and neurosurgery. On the other side, we've lost talking treatments years ago to our psychology colleagues. I think Mark mentioned the 1997 paper I wrote General Psychiatry in No Man's Land with Trevor Turner. The opening line, as I recall, was, "We became psychiatrists because we like talking to people. Now, if we want to talk to someone, we have to refer them somewhere else." And that was 25 years ago, and that hasn't changed. And, we are so often seen as all we do is diagnosis and prescribe, and that's all we're good for. And that is so wrong and so bad. And I mentioned the enemy without squeezing us: psychology on one side, neurology, neurosurgery on the other. I mentioned the enemy within, and all the non-medical prescribers, the physician associates, the advanced nurse practitioners. Look at the arguments going on in the news at the moment about the role of physician associates in relation to medicine. No one's even begun to address their role in relation to advanced nurse practitioners or non-medical prescribers in all specialties, not just mental health. So and again, what is it there? What are these people there for? They're basically there to replace us, because they're cheaper and they're arguably more expendable, which is sad. So time, we see patients. By the time I finished my last proper job in the Midlands, I used to see a new patient in an hour and a follow-up in half an hour. And that got reduced. And then with the introduction of IT systems and making our secretaries redundant, and we're having to type our own letters, I'd spend more time on the keyboard than I would in face-to-face conversation with the patient. And time is one of the things that's done for us the most, in my view, and making the time to see patients. And if someone else can do the admin, I'm doing a job in the Channel Islands in Jersey at the moment, which is lovely. And one of the amazing things, they give all their new doctors Dragon software. Do you all know about Dragon? Which costs several £100s, but actually jolly sight cheaper than the secretary, and it works well. But very few trusts do that, and you're left with either half-baked voice recognition that is so useless that you end up typing everything yourself. And of course, most of the secretaries who are hired these days aren't trained medical secretaries, so they don't know the jargon. So again, by the time you've edited, you might as well do it yourself. I mentioned mess and complexity and the retreat from complexity, and trainees and students being brought up to see patients as one-dimensional entities on a tick box form and ignore the complexity of their lives. And again, our role is just diagnosis and prescribing, I think, and not having the time to talk. And the effect of that on the therapeutic relationship is awful. In my last but one job, I was in Derry in Northern Ireland for a year, where they struggle to get doctors a lot of the time, and a lot of the time they do without doctors. And time again, every time I saw a patient and they left and they said goodbye, they'd go to close the door behind them, and then the door would open again, and they'd pop the head round and they'd say, "Will I see you again, doctor?" And that was absolutely heartbreaking, because especially if you're a locum, you can't give that guarantee. 0 hours contract, you could be gone tomorrow. So that therapeutic relationship, one of the things I think we should try and do with our juniors is teach them how to build that really quickly. So I learned a trick once upon a time as a senior registrar. I worked at Queen Square in the neuropsychiatry department there, and there was a wonderful consultant who everyone loved, called Mike Trimble. Some of you may have read his books. And Mike Trimble had a trick, and no one quite knew why all his patients loved him. But one of the things he used to do, and he'd see people in 5 minutes, quicker than a GP appointment. You might see them every 6 months, something like that. But he had a pen with a different coloured ink in, and he'd ask them one question about what was important in their lives. And it could have been their child's nativity play or sports day or any old thing unrelated to their neuropsychiatric condition, and he'd write it in their notes in the different coloured ink. And so when he saw them 6 months later, the first thing he said, "Oh, hello, Mrs. Jones. How did little Johnny get on in school sports day?" And of course, Mrs. Jones loved it. She said, "He remembered. He's amazing." And so there are little tricks like that, which is a little bit deceitful, but it works. And the trouble is, that I'm sure he gleaned that from one of his bosses years ago, but gleaned over many years of experience and experimentation. But I tell our trainees, no matter how briefly you spend with someone, to do what you can, make them feel important as a person. And the most important lesson about therapeutic relationships I learnt as a medical student was, I was told, always treat the person in front of you as the most important person in your life. Treat it as your mum, your dad, your wife, your partner, your lover, whoever. But when that person is in front of you, make them feel they have all the time in the world, and make them feel that important. And I was telling Mark earlier, in my first job as a house officer, you couldn't do it these days. I'd be struck off, but I've still got pictures of my patients. I took their photographs, and they're in my family album. I know their names. I remember what was wrong with them. And it's so sad that that's gone now. Really important. And then admin support, always ask, if you go for a job, what's the admin support? Because the secretarial situation is dire. And if you type like me with 2 fingers, you will end up spending more on the keyboard than you do talking to the patient. And the worst thing of all is to be talking to a patient and actually listening, but typing while you're talking, because that is, they perceive it as insulting. And they perceive it as that you're not listening. And I think even if we are, we shouldn't do it, because it's they just really don't like it. And then finally, I've almost finished. So expectations, we have a shifting culture. We live in an egocentric culture where, people are happy to attribute problems of living. And I don't want to, give adult ADHD a bad name, because there are a lot of very genuine, seriously unwell people. But there are people who are happy to have a psychiatric diagnosis because as an expedient for their problems of living. And of course, if they have that diagnosis, it becomes, you doctor, you psychologist, you mental health professional, it's your problem, not my problem, and you've got to fix me, and if you don't fix me, it's your fault. So it's you know, that's happened in culture across the Western world. And also just remember what we're all here for, whatever mental health discipline we come from. You know, we're doctors and psychologists, and we offer our specific treatment. So I'll give in clinical psychology, I hope I don't offend too many people in the audience, but you know, CBT, limited 8 courses or however many courses you offer. Sometimes you offer it online first. And patients come to you as a psychologist wanting to talk about themselves. And of course, you haven't got time to let them talk about themselves. So they just end up incredibly frustrated. Likewise, when they see the doctor, you know, we barely got time to talk about the medication and all of that. Whereas in the old days, we have to remember 100 years ago, patients had priests to go and talk to and get the life coach type experience. Now, unless they can afford life coaches, they use us instead, mental health professionals. And you know, as religion slowly erodes, and we're expected to take on all these additional roles that we simply haven't got the time to do. So, you know, it's my solutions very quickly. I think medical student selection and training, undergraduate training, still needs to be rebalanced. Absolutely important. When I was a trainee at the Maudsley, we had lots of outsiders on the wards. We had police cadets and we had trainee clergy. Just think who people with serious mental health problems come across as their first port of call. It's the police, and it's often the clergy as well. And I tell you, it wasn't just good in terms of educating the clergy and the police. It was good for the patients because they were perceived as being slightly different from the rest of the team. And they would share secrets and information with them that they wouldn't tell for the rest of the team. And it was worth its weight in gold. And I'm so sad that money's stopped that largely happening. I do think casualty, ED, A&E departments are where, again, a lot of mental health problems are dealt with. And I honestly think there should be compulsory psychiatric attachments, and there used to be for people who had been appointed as ED consultants but hadn't done psychiatry before. There was a well-known consultant who came to me for a month when we used to do this at a certain other London teaching hospital, who used to tell his students that all the overdoses and self-harming patients were a total waste of time and should be kicked out without any interventional help at all. Absolutely appalling. But when a charismatic role model starts saying things like that to young colleagues, mud sticks. You know, so I do think, you know, people who come near the mentally ill who are not mental health professionals should have some sort of attachment and should have some sort of experience in mental health. Eliminate. I honestly think we should. I've said this before. We should either be in substantive posts, or we should be trainers or trainees, and none of these non-training grades and locums, because it does everyone down, including themselves ultimately. Admin and secretarial support. You see, the trouble is in other specialties, it's not so important because the history in mental health is to everything. Whereas if someone's broken their leg, all you really want to know is they've broken their leg and maybe the past medical history, but you don't need the detail. And you know, in Northern Ireland, where I worked before, they're getting a new IT system that's coming in with a fanfare of trumpets, and it's supposed to be wonderful and marvelous. And of course, it'll be rubbish like all the other ones. But one of the things this IT system is not going to do, which we found out almost entirely in passing, is that all the historical information on the old system isn't going to be carried over, because the people developing the system were listening to the surgeons and people in general medicine who thought it wasn't really necessary. And of course, in psychiatry, we're going to lose all our patient histories. It's awful. So adequate admin and secretarial support. Now, here's something I tried to introduce here when I was here years ago, but never quite happened. I think after 5 years, unless you're a misfit, a mercenary, or, you know, I think you should have a change of job. I think people get a bit burnt out and get a bit of moral fatigue after 4 or 5 years. And I think at least offering people a change of job every 4 or 5 years is a good thing. And also, I think if you want to retain consultant staff, throwing money at them as a golden hello isn't going to work unless the golden hello is more than 10% of salary. Behavioral psychology, business psychology shows it doesn't affect behavior. But if you offer people, let's say a 3-month paid sabbatical every 5 years to do what they want, maybe you can say it has to be vaguely related to your job across the board, not just doctors, but psychologists as well. I think that would keep people in work. But I wonder how that happened. It's amazing, spooky. And finally, I think again, the time we spend with patients needs to be ring fenced and needs to be protected, and we shouldn't be eroded down to having to type our letters within that time. And I don't think we should be made to type in front of the patients. And I do think we should we should agree in our job plans that we only see a certain number of patients each day, come hell or high water, because otherwise you get pushed and pushed and pushed, and soon you end up seeing, you're asked to see patients in 10 minutes, which is not good enough. So anyway, some of that's going to be contentious, but things have changed a lot in my time. And there were bad things in the past as well, but I can't help being a little bit cynical as I get near proper retirement. But it's been a fun career, and I do it now because I love the patients, and I don't like a lot of the management and the bureaucracy, but the patients are great. I've always loved them, and I totally endorse what Femi said earlier about psychopathology, and just instead of just saying they're all psychotic. And you've got to look at them as an individual, explore them as an individual. Everyone's different, and their symptoms are different, and if we lose that, we've lost everything. Might as well go home. Thank you very much.
I think we can move this piece of furniture out of the way. And in fact, I'll ask you to join us. And bearing in mind, of course, we do not have a facility of microphone, but there's something reasonably acoustic about this unit.
Yeah, remember to shout, everyone.
Yeah. Well, where was it? One thing, just picking up, Martin. In fact, in many ways, this echoes the. All their clunking and bumping get over and done with now. Great. I just want to ask one question before, Madam at the back. I'll go straight to you. You use the.
I'm a consultant psychiatrist in medical psychotherapy.
Oh, going straight to the question.
You're a very rare species. I say you're a very rare species.
And I'm also the psychotherapy tutor for the London part of the trust. So I am in a place where I come in contact with many aspects of those systems. And on one hand, it sort of warms my heart to see what you have to say. And the other side is that I feel very sad that we have to keep saying these things that to me feel very self-evident. And I'm trying to understand and to think about why that is the case, why we have to keep saying those things. And we all know that from the Elizabeth Menzies-Leith paper about systems as a defense against anxiety, there is something about us creating those systems to protect ourselves from the complexity that we are encountering. And of course, and there is something very powerfully anxiety-provoking when it comes to encountering mental health problems and disturbances. So I think that is something that I keep going back to, and how important it is for us to work in groups to contain that. So there is the aspect of how systems try to contain that. They never do completely, they break down, sometimes trying to eliminate even the systems themselves to get rid of what makes us feel in a very difficult place. But now there's the other side of it, which has to do with what we were talking about earlier in terms of encountering complexity. And we are in an incredibly privileged position to be working in systems and in groups and in communities of clinicians that actually have tolerance for that complexity, and beyond tolerance have appreciation for the complexity of being human. And I suppose the last thing I want to say is that when it comes to the relationship between trainees and trainers, and I'm seeing, I know a lot of people here through my work as a trainer, and I think it's quite astounding how much talent we have in the room. How many people are incredibly invested and interested and engaged in doing this very difficult, very complicated, and very interesting work. And it's here, it's all around. And I suppose the trainer-training relationship goes both ways. because I'm learning from the people I work with every day.
Okay.
Can I just say just a partial answer to the first part of your question? I believe the reason, we all know that the therapeutic relationship is self-evident, but non-medical managers who hold budgets don't. And the trouble is, it's very difficult to quantify. And I think that's one of the reasons we functionalized in, was it 2006 or around that time, because managers wanted to break the service up into bits that could be properly costed. And I think that, they're ignoring the therapeutic relationship because it is hard to quantify and put a price to, really threw the baby out with the bathwater. And I say functionalization, I think did more, in my view, to damage therapeutic relationships than anything. And the second bit I'd say is, you mentioned how teams protect against anxiety. Well, when they work well, yes, they do, but often they don't work well. And what annoys me is when a multidisciplinary team wants to make a difficult decision, usually to discharge someone or not to accept someone into the service, and 90% of the people sitting around the table haven't the faintest idea who the patient is and have no interest in them, and no, and sometimes you can see them tapping away on their phones and playing games under the table and so forth, because they're not, but because it's the MDT decision at the end of the day, it sort of protects the person who is driving the case, the key worker or whatever, because everyone is so obsessed with defensive medicine these days and not, sticking to protocols, guidelines, not making decisions unless the team has made it. But the best teams, as you mentioned, the best defense against anxiety. I tell you, when I came back this morning, Mark invited me to he had a team meeting next to the Homerton Hospital, and afterwards, I sat outside a little cafe looking at the old Hackney Hospital, where I trained both as a student and worked as a consultant psychiatrist. And I found myself weeping practically. And I couldn't understand why I was becoming so emotional. And it was simply because in those days, my colleagues, although sometimes they were infuriating, no disrespect to you, Jeremy, wherever you are, but sometimes they're infuriating, but it was like a family. It was like a family, and we supported each other. And we cherished each other. That goes back to what I said at the beginning. We cherished each other. Likewise, our trainees who see what we did there as being faithful. And I still think of it as going home, actually. And it really affected me emotionally this morning when I went back for the first time in 30-something years. So I think you're absolutely right. Teams are important, but I think money and putting the bottom line first is done for the therapeutic relationship.
I mean, is there any point you'd like to make to our psychiatry colleague before we move on to the next?
No, I think it's all been made.
Yes, indeed. Okay. So, with a bit.
Just to preface, I'm only a registrar and even at that, but
no such
thing. Curious about your thoughts, because what to me seems to be a massive issue is the sort of exponential imperial capitalist drive of psychiatry to expand into kind of filling every gap of society falling apart, and it's sort of cure for all ills. And it was there kind of in your last slide. When that happens, it's completely impossible to do any of what we've talked about this afternoon, because the kind of caseload is now everyone. Someone feels a bit upset, they immediately needs to come to secondary care. And you can apply all of this and say, okay, well, let's limit ourselves only to severe mental illness, and we can do proper relational care because we're dealing with something that's manageable. But kind of where do you draw the line? And in a way, are we a sort of a victim of our success as a specialty? Do we need to kind of dial back and say, actually, there's not a great deal we can do. Let's focus on the people that really need our intensive help.
Femi, that's right up your BBC Street.
It's I mean, you are right in some ways. I'm not sure I totally accept your proposition, but you are right in some way. I think that if I start off with my bugbear, we've used the term in this afternoon of mental health problems, whereas I insisted on using, with the BBC program about mental illness, and I was irritating to them to the degree that I talked about diseases rather than disorders, and the idea of trying to understand the nature of a disease, to actually to put your mind around why the term disease is actually important. And it speaks to the issue you raised, because when you start to talk about mental illness and you start to talk about mental diseases, what it does is it focuses the mind so that you know what it is you're dealing with. But I'm reminded that there's this idea that the future belongs to diseases. And I can never remember the name of the philosopher talks about that, that the future belongs to diseases. And what it means is that there's a way, and we're not talking about psychiatry now, we're talking about the whole of medicine. And what it meant by that was that there's a kind of a way in which that diseases encroach on all of life. So you think of aesthetic medicine. I went to a conference just a week ago at the RSM on aesthetic medicine, and aesthetic medicine is dealing with ideals. So aesthetic medicine takes a look at themselves, and they think they've deviated from the norm, and then they ask a doctor to make a difference, to actually intervene. So there's a way in which there's a kind of way in which what is normal starts to encroach. So, and that's not just in psychiatry, that's across the whole of medicine. So in my own view is that maybe there's a need to start to use a slightly different language, which will force all of us. But I'm reminded, just to comment on what Martin talked about, that so in 1920 was when we discovered that that syphilis was caused by Treponema pallidum. And once we knew what caused syphilis, then it moved from psychiatry to medicine. And a large proportion of the people in asylums had tertiary syphilis, and it just moved. And so there's that. You have to be alive to the fact that I did a talk for neurologists in Cambridge about 18 months ago, and it just never occurred to me that we were competing with neurologists for dementias. Just never occurred to me. And the case conference which they had before my talk was all about dementias. So you can start to see that what had happened to epilepsy and happened to tertiary syphilis is going to happen, first of all, to dementias, because we know more and more about dementias, and there are more and more treatments in the pipeline, and it will move. And the same is going to happen for, whether we like it or not, for schizophrenia, because that's the next online. So we just need to be aware of that.
One thing, before we move to your question, Michael Shepherd wrote an excellent anthology, Psychiatrists on Psychiatry, about 20 years ago. And in it was a paper by the late Anthony Clare, late of this parish, and genius communicator and clinician, if ever there was one. And he made the interesting observation that psychiatry will be seen to have done its job, but it no longer is necessary. Let me comment.
I mean,
the topic areas. But the idea that we can, be specialised out of existence should be fine. We'll move on to something even more complicated. But do you want to comment any further on that?
No, just to say that I do hope, like I mentioned, the APA and the new electrical techniques that are being introduced. I just thought back to someone like Julius Wagner Jauregg in the 1920s and some malaria treatment of mental illness. We've seen so many false dawns. And I just remember going back to Fenner's talk at the beginning of his talk, he talked about Professor Robin Murray. And I remember when he interviewed me for my place at the Maudsley, he got very excited and he banged his fist on the desk and he said, "There's never been a better time to go to psychiatry. In your professional lifetime," pointing at me, "we will know the answer to schizophrenia." Ha. Do we heck,
Well, on that heart, we'll go to the next question.
Propose an offer in terms of one of the solutions. So I'm a specialty doctor, so I guess I fall into the non-training grade that you're talking about. And we're now about 25% of the workforce, and we're diverse. And some of us have MRC psych and some of us don't. Some of us have senior roles within the trust, some of us don't. But I guess my point is, and elimination seems a bit strong to me. We are a part of the workforce. We provide lots of clinical care and actually really good quality clinical care in most cases. And I'm really proud to work for ELFT because actually ELFT does a lot to support staff doctors and in terms of career progression. I think it's, I don't think we can continue on this view that you either need to be a consultant, a consultant or a trainee. I think that just doesn't work in the system anymore. We have so many doctors in this group at ELFT with huge amounts of experience, some from overseas. It's a very diverse group. And I just find the idea of eliminating locums and non-training grades a bit old-fashioned.
I do think what particularly upsets me is the deception of young doctors that they will become consultants through the CSER process rather, when it's really hard. And I think there should either be those of you who are doing the good work as you are at the moment, well, you know, call a spade, make you consultants. But I think they should, you know, there's so many people in limbo. And if you're well employed, if you're well paid and you're doing a satisfying job, that's great. A lot of people aren't around the country. They've been sort of sidelined into it. The trouble is once you stop revising for the exams, once you get off that ladder, it's really hard to get back on it again.
I guess my point is not everyone wants to be on that ladder. And if you're providing good clinical care and you're part of a trust that is kind of values you, then it's not, I just don't think it's as important. And I think that we risk losing good doctors. And there are a lot of reasons why people don't pass the exam and why people don't get into training. And I could talk about this for a lot longer.
Absolutely,
yeah.
but it does.
I find this kind of thing is not really helping in terms of looking at the workforce.
But it does beg the question: if you're doing an excellent job, what's the point of us? Why employ us on our high salaries and all of that?
Okay, we'll leave that hanging in the air, Jeremy.
Yeah, I've really enjoyed this talk today. Makes, you know, reflects back. One of the things I nearly said would have interrupted you about East London. Actually, East London's a very special place. I can't tell you what the current situation, but you talk about Robin Murray. Robin Murray gave me the ESOL protocol back in the late 90s. I effectively copied it and got some research money. But do you know that in 2000, East London, the three boroughs, and SLAM, what would be SLAM now, three boroughs of SLAM, which include Lambeth and Camberwell and Lewisham, have the highest rate of new cases of schizophrenia and all psychoses generally, equal per 100,000 people in the literature ever recorded in the world's literature. Not many people know that. I've never been able to actually talk about research actually in this sort of setting. And I think that actually makes a real big difference, that actually different places are different and you do different psychiatry in different places.
Absolutely.
You also, in terms of your training in the situation, it's different who you work for. And one of the things I think that psychiatry is difficult, it used to be that you could retire earlier. You could retire at 55 on a full pension because it was accepted that you had taken on a profession that was more difficult than other people. That causes ridicule now, but that was how the case was. So I have contemporaries who retired at 55. They couldn't get, they had to get rid of me. But, so the other thing I was hearing about, something I thought really interesting, was actually that came up with Russell's. And so I was not entirely agreeing with Russell's approach, but when I started training at the Morley, after coming from Sheffield, actually, I started off in an asylum in Sheffield, was actually virtually everybody was in personal therapy. Now that is a really, hands up, how many trainees are in personal therapy? It might have probably half would have been in a room, maybe more. Yeah, but it was beginning to become less sort of, you know, in therapy. Well, I needed therapy, but The other thing I would say that came over was actually you talked about Hackney, the old Hackney Hospital. Actually, one of the things that carried you through dealing with what was a really challenging sort of profession was actually your colleagues. But actually, that was the main thing. And so, what I would say has become so awful is the sort of separation. And that gets into perhaps my big bugbear, because I'm always in trouble these days because I'm constantly posting on LinkedIn. And I have a sort of obsession. Well, I have two obsessions. One's the new mental health bill. Let's not talk about that today. But actually, beds. I have an obsession with beds. And I'm sort of so delighted. I don't know about Femi. To me, it's almost like beds are everything because there aren't enough of them. But actually, you cannot practice psychiatry in a sensible way with the number of beds that we have. Everything seems to be affected by that. And so you have to go back in the research to Thornycroft, who actually suddenly twigged, even though he'd been pushing, close as many as possible, suddenly changed it and started saying, hey, we've got an imbalance. And that's about 20, 25 years ago. So I don't know, what do you think about my obsession with beds? I'm obsessed with them.
Femi, I mean, you mentioned the B word first of all.
I mean, I think a young psychiatrist I was asking me during the break, about beds, and I had to just give the facts of my own career. So I was appointed consultant in 1986 and covered Hall Green, which is just one electoral ward in Birmingham, population of 24,000. And I had 15 beds in 1986 to look after 24,000. And we moved from John Conley Hospital, where I initially started off, to the new hospital, Queen Elizabeth Psychiatric Hospital, on the grounds of the Queen Elizabeth Hospital. And my catchment area was increased to Foxhollies and Hall Green, which is a population of 48,000, and the beds had reduced from 15 for 24 to 7 for 48,000. And in today's world, those two catchment areas, the Hall Green and Foxhollies, they're lucky if they've got 3 beds. So
There's one in Devon.
Yeah, absolutely. We're encroached on Devon. So there's a real fact that they're not made up, and you could argue that when I was first appointed, the 15 beds, there were probably too many beds, and I could just about manage 48,000 for 7 beds, and Giles Glover, wasn't his name? Giles. Giles had a kind of algorithm for working out how many beds you needed. And he and I corresponded because I was medical director about the same time, and here we corresponded quite a lot. And I used a system, and 7 beds for 48,000, and they were outer city wards, so that I wasn't covering Spark Hill or Spark Brook or anything like that. And he and I agreed that was just about all right.
Yes.
But what we've got for Hall Green and Foxhollies in today's world is not all right.
Yes.
There's just no question about that. And I don't think we should accept the idea that somehow if you had more community beds or community services, that somehow that would obviate the need for beds, because people are acutely ill. And the facts at present in Birmingham, I can't speak for London, is that they're having to search for beds all over the country. They're not, and there are people already detained with the papers already signed who are in the community, because there are no beds. That's just how it is, and that can't be right.
That's routine.
And within these 4 walls, there are people waiting to go in who then kill somebody, and that's true. I'm not making it up. So I think that, and Darcy talking about too much money on hospital in mental health, not in the general hospital. I just think whoever is advising him, the guys who are sitting on his committee, I just think they don't know what they're talking about. That's my view on it. I just think they have no idea what they're talking about, because we just need people to be able to be in when they're seriously ill, and there are people not able to get in when they're seriously ill. And it does make the life of the people who try to look after them, it just makes it a little bit more difficult.
Actually, anyone here, just before I get another question, anyone here actually run or set a ward? Consultant single-handedly charged a ward. Is that you?
Yeah.
Good.
We have so many beds that we're selling them in Hackney.
We're selling 4 beds, maybe.
Selling beds, yeah, Tower Hamlets is doing it as well.
Yeah.
That's very interesting.
I think the argument for community service, isn't it, that you would then you prevent some of these relapses. So the idea is that you've got an adequately resourced community system with a kind of infrastructure and a network of wellbeing support and sort of services that can help reduce the stress on individuals and support them to meaningful work and life activities. Is that you will and support them with their medication, that you will then reduce the number of relapses, so you won't have this kind of build up that you've had now in the system that's breaking. But I think that's there's good evidence that you can reduce this demand, and the idea that all these people are acutely unwell who need a bed, that's not representative of what the hope would be, which is going to be a lot fewer of those people acutely relapsing, but they be picked up earlier and then treated ahead of that sort of acute crisis.
So if I might respond,
Please do.
so the key words in your intervention are hope. I don't know whether you're monitoring your utterance as you were speaking. This is what we hope. And then I use the word promissory note. Promissory notes, they're some of the most complicated ways of speaking in modern society. So I usually quote. I've got my iPad. I usually quote Chekhov for promissory notes, and Chekhov in ward number 6. If you haven't read Chekhov ward number 6 as a psychiatrist, you ought to go and read it. And short story, yeah. Very easy to read. It take you about an hour. And he says, this is in ward number 6, because the psychiatrist in ward number 6 to say, where is it? Compared with the past, psychiatry, with its current classification of diseases, its diagnostic procedures and methods of treatment, had taken on an enormous leap forward. No longer are they insane doused with cold water, nor are they put in straitjackets. They are treated as human beings. And according to newspaper reports, they even have their own dramatic entertainment and dances. Rajin knows very well that with modern views and tastes as they are, such abominations as ward number 6 are possible only in a small town 175 miles from the nearest railway, where the mayor and the councillors are semi-literate barbarians who look upon doctors as high priests who must be trusted blindly, even if they pour molten lead down the patient's throats. And that it's a wonderful, wonderful capture of the voice you had. The idea that things will be better if only we did them better. Brexit, if only you made it good. So promissory notes, just keep in mind, when you hear the rhetoric of promissory notes, remember that promissory notes very, 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 very rarely deliver. They're eating the dogs.
Yeah, I'm Peter Byrne. I work next door as liaison psychiatrist and I'm public mental health lead for the college. Just before I make a point, I thank and support our SAS doctors. I think they do an amazing job. Misrepresent them, but I'm not going to speak about that. I'm definitely not going to speak about beds or Brexit. And I kind of want to break the consensus, Danny, because I don't agree with you that there's no point in applying ourselves to prevention, okay? Because whether you call it mental illness, mental disorders, there is a tsunami of mental health conditions in children and young people. It's absolutely off the scale, and it's coming our way, and we'll get them all as adult psychiatrists on the week of their 18th birthday. I get them booked into my 3 clinics across the way on the week of their 18th birthday, where CAMs have just said, we're done now, off you go. And there's a reason, I think, why East London and Slan get the highest rates of psychosis. That's all about poverty and inequality. This last government put an extra 1 million children into poverty, and they wonder why there's higher rates of mental disorders. Well, that's why. It's also about adverse childhood experiences. We should prevent those. It's a public health emergency. While we can't, we should try to prevent them, we can mitigate them. And that's again about prevention in psychiatry. We can do these things. And I think the story isn't just about stigma discrimination in East London and Slan. It's stigma discrimination, racism. And that's they're the things that are driving very high rates, I think, of psychosis. We can see then what precipitants are, and it changes. But the prevention strategies aren't just within psychiatry. We've got things like Sure Start. We've got proven anti-bullying programs in schools. There's lots of things we can do with people as they make difficult transitions from, say, school to work or school to college or university. But the government at the moment keeps saying, we're going to do some prevention. And it's just, it's like Wes Streeting. If you did a consultant interview and you said, what do you want to do? And you said, I want to do prevention. And the interview panel said, what sort of prevention? And Wes Streeting says, I don't know. I've had 14 years to think about it, but I don't know. We're going to do some sort of prevention. Maybe you can have a consultation on prevention, and that could run up to the next general election. But let's not do that. But I do want to say to you that our college is doing things in the public mental health space. There's an e-learning course. There are things that you can learn about. But the evidence is most definitely there that we can prevent many mental disorders, and we can mitigate with cross-community good public health activities, and we shouldn't just wait to be overwhelmed with growing referrals. So I just wanted to make that point.
Can I respond?
Thanks, Barry.
I think the response, I mean, obviously, you are right. But
That's always a problem, isn't it?
I suppose the point I'm making,
yeah,
which I think you can't argue against, is the idea that services for people who are ill, which is already very, very fully funded, that some chap who's just been appointed Secretary of State for Health wants to move some of that money to something which he thinks is going to prevent psychiatric disorders. And I just don't, you have to work very hard to persuade me that it makes sense to move money which is under-resourced from the service which is under-resourced.
So that's what he says. What I'm saying is it's not either or, it's both and. Yeah, you can't at one stage say we'd like mental health. There's a problem, and the politicians say this all the time. So of course we need those services. I wouldn't argue for a moment that there should be. I agree with Jeremy. We need more beds. I agree with all of that, but we also need to properly resource prevention with things like a whole school approach, with things that we know work. The problem with the last guys is they did pilots for everything. They had more pilots than Ryanair. It was just all. They never evaluated them properly. When they were evaluated, we realized that mindfulness in schools, Russell isn't here, I can say it, is bullshit. It does nothing. It may make teachers, give them a break so they can have a fag break, whatever, but mindfulness in schools achieves nothing. So why do that when you could do an anti-bullying program or something that's evidenced and you can prevent mental disorders? So I think these are the sort of things I would love our trainees to take an interest in, and new consultants, because we can work in that space. Psychiatry, when it tried to solve every problem in the 1970s, got a big fall in the US. We're not going to do that, but we are going to speak sensibly, because we do understand social determinants, we understand commercial determinants as parts of that, and we can do good things.
Good point, well made. Yeah.
Hi, I'm Ian Kosko. I'm an adult psychiatrist and was medical manager here, and I've been around a while. I think what's really sad is when we argue about the same issues from different perspectives. We need more resources, we need more prevention, we need more care in the community, more resources in the community. The elephant in the room is the reason the beds were cut. Many of the beds were in old asylums with lots of backlog maintenance. They were sold to generate money. They're all housing estates now. So actually the debate should have been, how can we reduce the demand for beds? And where's the evidence before we cut the beds? We cut the beds, and now picking up the pieces. Forensic services are stuck. Nobody's moving through by and large. I spend all my time now doing delayed transfers of care in East Anglia. Social services have no beds, no residential care. So adult wards are stuck with patients who shouldn't be in the community. So we're looking at things and arguing about showing more beds and more resource. We need more resource and much more radical rethink. Those are my views.
But not a question. David.
Well, yeah, I'm not a doctor, I'm an art therapist, and I've worked in acute on the wards, and also in community, charity for mind for many years. And I think you need both acute, I think you need both beds, and you need also community care. You need people to be known. And when you talk about continuity of care and getting to know and actually developing a relationship ongoing with people, I think that's very, very important. Not treating people as just, you know, cases, because it's human existence. And I think you need both things, and it involves philosophy, it involves, you know, intimate, you know, communication with people on an ongoing basis. And so I think it's not either or. You know, that's what I want to say. You know.
Sir, do you think
Yeah. Hi there, my name is Phil Baker. I'm a psychiatrist in the trust, but I will disclose now I'm also a medical manager, so that may influence some of what I say here. But
That's important that they get into that.
I think some of what's been described, particularly in the last talk, is depressing. And I think it's depressing for perhaps different reasons than you find it depressing. I worry that people hearing some of what's been said would think that psychiatry is not a rewarding, enjoyable career to go into at the moment. I think that's not true. I think most people still really enjoy it despite the challenges. I think some of the language used, I was thinking about the way you described the professor of whatever it was, so we're going to get back to proper medicine soon, don't worry about it, with one of you or one of the others. Think about the way you described some of our colleagues as enemies. I think it's an inappropriate type of language to use for these people. I work with SAS doctors who we've already talked about. I also work with nurse consultants, ACPs. We have all different professional backgrounds who provide an incredibly valuable service in our trust, and they are absolutely not our enemies. And I know you're not describing them as individuals as enemies. I know you're describing a risk to profession, but I don't recognise it. We've also seen the numbers of consultant vacancies for psychiatry is so much higher than everything else. So the idea that these people are all there to replace us just doesn't stand up to scrutiny. It comes across as a little bit paranoid, I think, actually. And as I say, my worry is what message that implies to people. I worry about I think, anachronistic view that there's managers out there to kind of destroy the profession. In this trust, we have managers who are almost all clinicians and who work in nothing but best interest in the services in mind.
Well,
So
yeah,
I was just going to finish one final thing. So I think it's not that everything you say I disagree with, I don't, but I do think the way we talk about things is just as important as the way those professors of medicine talked about people that we became.
Martin, back to you.
First of all, I think sometimes it's necessary to not embellish, but to be, to put an argument as robustly as possible, to have the argument, because otherwise we pussyfoot around and tread on eggshells. But let me tell you why I retired from my main NHS job back before the COVID lockdown. And what had happened was this, and I'm not blaming managers here, but what had happened was that I was under continual pressure to cut my caseload. I had a caseload of about 350 patients in a community team. And these were patients with most serious enduring mental illnesses. But the managers immediately above me were under pressure from the CCG. The CCG had decided they wanted consultant caseloads cut. So the deal was, and I said, look, these are some of the sickest people I know. They've been followed up, for a long, long time. They're seen as sparingly as possible. We can't just discharge them. But the deal was that if they were sick but stable, so psychotic persisting symptoms but stable, that they would be discharged, and they had a fast track back into the system if things went wrong, if they became unstable. And what happened several months later, I started hearing the same story coming from patients again and again and again, and there was 5 untoward deaths. And basically what happened was that the fast track process back, the patient would phone in this particular phone number. It was answered by a member of an admin team whose previous job was she was 20 years old, and no disrespect to McDonald's, but her previous job had been in McDonald's and had no particular training to deal with severely mentally ill patients on the phone. And she would say to them, you've got to go back to your GP and get referred. So 2 or 3 weeks wait for the GP. GP would get very bad tempered because he'd say, hey, why am I referring this person back to you? You know them 10 times better than me. You've known them 10 times longer. So the patient waits 2 or 3 weeks to see the GP. Angry GP needs assuaging. And then the patient has to wait a week or 2 to see me again. By that time, 5 or 6 weeks has gone. In that time, 5 patients took their own lives, and a number of them were, just deeply upset. And they had the experience of just being pushed away when actually they should have been embraced. And
I actually I borrowed a patient's identity in the end because I thought, I don't believe this, I just want to test the system. And I pretended to be a patient and rang up the fast track number. And I got exactly that story. You've got to go and see your GP, you've got, and it wasn't the sort of response. So the point is the manager was under financial pressure to meet financial targets from above. He had no choice. But that tension when, the clinical, what's happening on the shop floor meets with the financial, the financial situation, you get a very difficult boundary that has to be, and sometimes it can't be negotiated, but that's why that's what shaped my recent views anyway, that experience.
My gut instinct as the chair of this rather interesting afternoon is just twofold at the moment. The first is it's 25 to 6, and the second
Yes.
is that could anyone like to add with a quick happy question? Any hands up there want to treble? I think, hang on. They can't come from a forensic professor. No, you had and you question place.
Natalia Wadinska. So just the question for you, maybe for junior doctors, would you spend more time on electronic patient than real patient? That's my 100% sure. And I changed careers. I was an anesthetist, and I realized that I really spend more time with unconscious patients that doesn't really need me that much. Like psychiatry. So the question to panel is, what would be your suggestion for us for resident doctors very early in our careers, how to how to spend more time with the patient rather than electronic one?
Yeah, I think that I retired in 2021, and if you'd asked me in 2021 whether starting all over again when I was in 1978, and I came into psychiatry as a 25-year-old, would I have spent 44 years in psychiatry? Would I have chosen psychiatry again? And the answer is yes.
Absolutely.
So I think there's a lot of kind of feeling that we'd like things to be better, but there's no question in my mind that I chose the right job, right profession. That's just true. And I thought that Martin talked about sabbaticals, and I've never had a sabbatical, but somehow I've arranged sabbaticals for myself. So I've done a job in psychiatrist job. I've done a lot of other jobs. I've worked in the college and working in exams or whatever. So there's a need, I think, to keep in mind that just doing this clinical work, which is kind of very, very stressful, that you need to find a way to refresh yourself during your career. And if there's any message at all for a young person who is just coming into psychiatry, is to keep in mind that there's a need to find some means to have a new experience every so often, just to keep you on track. And that wonderful thing of keeping in mind, having this spark that brought you first into medicine and that brought you into psychiatry, and having a picture of that, to have a kind of visual memory of it, so that every time you come to have some stressful situation in clinical work, that you can dip back into that memory of why it is that you are in here, and then I think that will be sustainable.
Yeah. I totally agree with everything Fen has said. I'm back working full time now, and I'm not doing it for the money. I do it because I love the patients and I love the clinical work. That's what keeps me young.
Keeps you young. Well, yeah. On that very note, then, can I just thank Dr. Everybody, Martin Dean, and of course the adjunct.